Light us up. All right. This meeting's come to order. This meeting's come to order. Morning and welcome. This is our last PEB board of the season. Our meetings are going to continue to be hybrid. HCA staff will be on site. Board members and other attendees have the option of attending on site or via Zoom. For our Zoom attendees, our opening slide has information about how attendees can turn on closed captioning. Let's go ahead and do a roll call, starting with Harry. Here. Tom. Here. Sharon. Sharon, are you with us?
I am here.
Excellent. Elliot.
Here.
Kurt. Here. Kyla.
Present.
And John. No John. Okay. And Michael Tunick from the AG's office. Present. And I'm Lou McDermott, filling in for Sue Birch today, and I'm the deputy here at HCA. With board members attending both in person and virtually, it's helpful for the board to hold their questions after each presentation is done or when the presenter pauses and asks for questions. Board members attending virtually, we're going to be watching for your Zoom hand. There are going to be several resolutions for action today, and the public is going to have an opportunity to provide comments on those specific resolutions during normal procedure before the board votes. And we're also going to have the public comment period at the end. And as a reminder, if the public has questions during the staff presentations, the presenter's contact information is at the end of the presentation with the email address. And if you want to send them an email, they will get back to you after the meeting. Dave, why don't you tell us what we're going to be doing today?
Great. Good morning, Chair McDermott, members of the board. We're going to start off. I have an unscheduled follow-up topic to bring to the board's attention that I'll start with in a moment here, but then we'll move over to Beth Heston, who will bring us some information about Kaiser Washington's end-stage renal disease program. There were a variety of questions about, reauthorizations or eligibility requirements or some of the nuts and bolts of that particular program. And so Beth is back to give some follow-up on that, which is important to do before we ask you to vote on the plans that include that change within Kaiser book of business. And that's what Tanya is bringing back with 3 resolutions on the employee / non-Medicare retiree premiums. Then Molly Christie will tee up the votes and any final questions related to the Medicare portfolio and the premiums there. And then you will have your final presentation from Ellen Wolfhagen. She will be retiring before next board season. And so this will be her final presentation to you about some of the ongoing work in the Medicare portfolio as we transition into open enrollment, which then brings us to Alyssa Richards, who will talk about open enrollment in general for everyone and the agency's preparation for it. And then the last major substantive topic today, Kate will be bringing us an overview of where we are on the various topics on the PEB consolidation report that the legislature tasked the agency with. And we are kind of kicking off our description of how we're thinking about different parts of the report and some of the high level, hopefully answering some of those high level questions that we're kind of in the immediate aftermath of the legislative session and people trying to understand some of the what was being asked of the agency in that report. So then I will just remind everybody that it's basically 2025 and start marking your calendar for the board meetings. So that's what we're doing today. As a quick just housekeeping reminders, if we have an emergency, walk purposefully across the street into the visitor parking lot. And if you need the restroom, go down the hall and look to your left if you see elevators. So that's the housekeeping pieces. So my unscheduled update concerns a topic that has come to the agency's attention in recent weeks, and it involves the intersection between the PEB and SEB programs. And so this is actually a discrepancy that relates to SEB subscribers waiving their SEB employee medical coverage in order to try to stay enrolled in PEB retiree coverage. So think of it right now as an individual who is enrolled in PEB retiree coverage, one of somewhere in the non-Medicare Medicare portfolio, and the scenario that keeps coming up is they are substitute teaching in a school district, and they suddenly, near the end of the year, meet the eligibility requirements in the SEB program, which is to be anticipated to work or actually work 630 hours in a school year. So they're going along, they're in PEB retiree coverage September, October, November, December, all the way through, and then in the spring they hit 630 hours. They get a SEB eligibility determination for benefits, and they may be then looking at employer-sponsored benefits in the SEB program for a few months until August That's the end of the school year. Eligibility reboots for them in the SEB program in September, and then they may not be anticipated to work the next school year, so then they would be transitioning back to PEB coverage. So there's this seesaw effect within coverage that is happening, and so we've had a lot of questions about that. So I want to start with some background information and build from the ground up. A lot of this is very fresh. There's no materials in your book on this, but there is more to come on the topic. So we have to start with federal CMS, Center for Medicare and Medicaid Service Requirements, and they have a couple of primary preventive themes in them. They are trying to prevent employers from incentivizing Medicare coverage over employer-sponsored coverage. And this is really about not shifting employee healthcare costs from employers to Medicare. So you can kind of see where this is all going. CMS regulations also specifically address situations in which there is a temporary period of employee eligibility for employer-sponsored coverage, which is the exact scenario I was just describing, a few months where you suddenly have access to employer-sponsored coverage. And these federal requirements really limit both the SEB and PEB programs' options to address retirees who are rehired or work part-time and want to try to maintain uninterrupted PEB-sponsored Medicare retiree insurance coverages. And then one more piece of this is the rules and regulations for pensions and healthcare are different when it comes to rehire and reworking, which understandably frustrates both school districts and retirees who may want to part-time substitute. So here's where this all started to come to percolate up in recent weeks. So earlier this year, this board passed a resolution, PEB 2024-11. And that resolution simply added the letters SEBB into a former resolution that the board had passed a couple of years ago. And so the goal of that resolution, it is adding eligibility that if you have access to the employer contribution for SEB benefits, that would be a reason for an automatic deferral for your PEB retiree coverage. And this was to align with current rules that exist for PEB retiree subscribers who gain access to PEB employer-sponsored benefits. So we already had in place a prohibition on waiving PEB employer-sponsored benefits if you took on part-time work and met the eligibility requirements in a PEB employer. And this resolution was saying we'll also have auto deferral when that happens if you become eligible in the SEB portfolio. The original intent of that resolution was so that PEB retiree subscribers would not have to submit a deferral form when they became eligible for SEB employee benefits. So this resolution then brought to light a disconnect here at HCA. HCA leadership, myself included, believed that SEB employees were already prohibited from waiving SEB employee medical coverage in order to try to remain on PEB retiree insurance coverage, because that already existed on the PEB side of the house. You couldn't gain eligibility for PEB employer benefits and waive them to stay on PEB retiree benefits. We all believed in the leadership capacity that Resolution 2024-11 was merely reducing paperwork requirements for now school eligible employees and making sure that they didn't inadvertently lose eligibility to come back into PEB retiree insurance coverage when they no longer had those SEB sponsored benefits. But myself and other HCA leaders recently became aware that understanding was in fact incorrect, and that HCA has been allowing some SEB eligible employees to waive those SEB employee medical benefits to remain on PEB retiree coverage. So what we're doing with this recent awareness is we've identified the inconsistency and where it exists within rules and policies, and we're going to be aligning everything to comply with the federal requirements, because HCA can't allow persons who are eligible for SEB employee benefits coverage to remain in PEB retiree insurance coverage, as that would likely be an impermissible cost shifting of employee costs to the federal government. So we understand now, this is really just in the last 2 weeks, that this is a change from the perspective of a SEB benefits administrator, a retiree, and even customer service here at HCA that supports SEB BAs as well as retirees. Certain SEB program rules and our special open enrollment matrix, which is a policy, administrative policy that many people rely on throughout the state in making eligibility determinations, included language that did not prohibited and actually even permitted such waivers, but only in the SEB program. If you line up the PEB and SEB rules, there is a sentence that's missing on the SEB side of the house that expressly prohibits this type of waiver. And so this is why BAs at school districts and retirees receive the guidance that they did from HCA customer service, because they were reading the policies and procedures that were codified and saying this waiver is allowed. Sub-program rules and the special open enrollment matrix are being revised and will have the effective date of September 1st, 2024, which will then clarify and establish clear compliance with the federal requirements. And we may have additional rules and policy clarification work on this topic. We do have a cohort of individuals who are have been in this waiver status that we need to address. We have some more research and cleanup to do in that area, but we do need to right the ship and make sure that these waivers aren't allowed, which is what many of us believe was the actual structure that had already been put in place. So we have retirees who are understandably frustrated. They learned that they can't be waiving. It's very understandable from the retiree's perspective. If you are moving from one set of benefits to another, then that means you might have your accumulators reboot. You might have to start your deductible over. But the other side of that equation is Medicare requirements don't allow it, and that the premium is more heavily subsidized when you're an employee than when you're a retiree. So there is a premium advantage, but there are a lot of circumstances individually where people might try to weigh and go, I'd rather just stay. They want to stay, but they can't stay in their retiree insurance coverage because that cost shifts things to Medicare because it's only for a month or two. But unfortunately, that does directly run afoul of CMS requirements, because CMS is trying to, for one thing, protect the Medicare Trust Fund. So we've had a variety of ideas and questions that have come to the agency in the last couple of weeks. They're like, well, can the SEP board just authorize this waiver because it's been allowed all this time? No, unfortunately, that we didn't here at the agency think that it was allowed. It actually isn't allowed. So we have to clean that part up, and two wrongs don't make a right, so to speak. So we have to right the ship on this one. And the SEP board really couldn't authorize the waiver. So the only thing that was left was what we thought we were doing and brought to the board a couple months ago, which was reducing the paper administrative burden related to the deferral process in PEB. So it's a very, unfortunately, complicated scenario. We are beginning to we're going to roll out some more communications and something very similar to what I just said here at the board today. And I said something very similar yesterday at the SEP board meeting yesterday that helps people understand the why this is happening and try to help people through this transition as we get in alignment with federal requirements.
And Dave, I thought yesterday you brought up a good example about DRS and about people sort of understanding what the rules are so they can adjust. And it's been a similar scenario that's existed for a long time at DRS.
Yeah, that's a good point. Yesterday, there was a board member on SEB asked about I think it was the business administrator from the Olympia School District. She was asking about the communication aspect of this. And I drew the analogy to many retirees are very familiar with DRS's retiree hire rules that if you hit a certain number, the impacts on your pension benefit. And now we need to, at this agency, do a clear job of the rules are different because pension and health is different regulatory frameworks. So unfortunately, we can't make this hours be the same requirement and align with DRS. But conceptually, we need to make sure people have the awareness of if you hit as a substitute 630 hours in a school district, this is what is the result of that. And then they can make an informed choice about, have an understanding of what the impacts are of working a certain number of hours in a school district.
Leah? You have a question?
I have three. One is a recommendation. When remember there are these before you retire, I remember this, you go to a seminar and you guys are there.
Mm-hmm.
Maybe this would be a good thing to add to that in addition to written materials, because we took notes and people are very aware they don't want to get in trouble. That's number one. Number two, actually I got four. I would love a copy of your written analysis, if that is okay.
Yeah, we're working, it's kind of in draft form to be a communication out to benefit administrators. And so when it's finalized, we'll send a copy of that. The same thing that we send to benefit administrators, we'll send a copy of that to the board.
Thank you. That would be great. I read this stuff at night. Okay. The other thing is, may I have a copy of the federal rule that you've been referring to?
Yes, I believe it's a 90-page packet, but yes,
Yes, you sent me those before,
yes.
and I've appreciated it. And then, the last thing is there anything for PEB to do? Do you want our board to take action of some kind?
At this point, no. I wanted to, there's been the way the questions have come up in recent weeks. It really started when there were some when we pushed out the information about the resolution that the board passed. I think it was in April. Some school districts said, but this is a complete policy change. Now some substitutes aren't going to be able to work and they don't want to take these hours, or, they were asking these questions. And we were answering like, this has never been allowed. And it wasn't until literally 2 weeks ago, a benefit administrator from Seattle Public School District was like, that they have been waiving this whole time. We're like, wait, what? And then here we are 2 weeks later. So, we were under a very deep impression that this wasn't allowed. And so I wanted the board to know, because some people have said, hey, why did the PEB board do this, make this big change? And then for weeks I've been saying, actually, the board didn't make any change. So I wanted you to know, like, because the power of the board has been central to this, as well as why didn't the sub board take action? So both boards, like, what their authority is on this topic, and this really is falling into one of those areas that the agency has to ensure compliance. But we've already brought you the things to make it compliant. It's just, it wasn't fully implemented in both programs the same way. And so all the structure that we think we need is there, but definitely reserve the right to come back next board season and go, oh, here's some more cleanup. Because I think as we dive into this even more and more, especially with the cohort of individuals in recent months that have been kind of navigating this unknown change situation, there may be some other things that we need to bring, but there's nothing today. And we want to be very deliberative about that process. So there could be something next board season, but nothing right now.
Thank you.
Very
If I could bring the piggyback on what Elliot was saying, the recommendation that on the outbriefing is people are retiring, that there be something on the school system side, which there probably is, or would be on the receiving side with new employees who are recognized, aren't eligible, but could be down the road. They clearly understand the rules, so to speak, or if appropriate, have some kind of written piece that can be provided to new employees that they didn't pick it up when they were leaving state employee system, that they catch it on the other end, if that's helpful.
Yeah, and I think it's an excellent idea for us to work. DRS obviously has robust communications about their retire, rehire, rework pieces, and it's another opportunity that maybe we can collaborate with DRS to have that information alongside of that, so that anyone could be thinking about substituting, and it might be a great collaborative effort with DRS.
So, are you familiar with the UNICEF councils through WEA?
I am not. That
Okay.
is not a phrase I'm familiar with.
Okay, so when you retire, a lot of school districts actually don't do much in terms of retirement, where they talk to you about different options you have when you retire. But the UNICEF councils, which are run through the Washington Education Association, have divided up the state into, they're called councils. So for example, here in Olympia, all of the school districts in this area belong to the Chinook UNICEF Council. And they do a very extensive retirement seminars. And so one of the things you might consider doing is trying to coordinate through the UNICEF councils. And you can do that probably through WA and WA Retired, to add that into the piece, because they do talk about, I attended one of their sessions when I retired 22 years ago. And,
Nice.
and,
Not as long as I have to go till I retire.
yeah, they do a very good job of informing. Well, for example, that's why I signed up for the healthcare authority. That's one of the things they said, you go down and do that as soon as you're eligible to sign those forms. So I did. So I would definitely say that is a great way to get that communication ball rolling. And again, every area of the state is covered by a UNICEF council. I think on the SEB, one of the original members was president of the Spokane Education Association. I don't know if she's still.
Katie Henry.
Katie Henry, yeah.
Yeah, she was a sub board member for 4 or 5 years. She's
Yeah.
not currently, but she was, yeah.
And I know that she was very active in the Spokane Uniserv.
No, that's a great tip. Thank you. That's not a structure I was aware of yet. So another good opportunity. Elliot?
Yeah, I've gone to the DRS presentations and we rely on that because literally in my department, I was told, go to the DRS presentation. We don't provide you with any advice on retiring. That's not our job. So I think it's also helpful to have it as part of the oral presentation, you know, with the example, because when you're sitting in that room, and correct me if I'm wrong, guys, you're given a lot of data, you're given a lot of paper, and the speakers are great. And so they give examples and you remember what they say. So if you could have a speaker talk about these hypotheticals, that would really help.
Yeah, I think that we have a much more regular work group with DRS that we've developed in the last year. And this is a great topic, I think, that we can certainly collaborate on. It's a really good opportunity, especially because the threshold for sub eligibility, I can't tell you, being roughly 22 years away from retirement, what the rehire work rules are today, but I'm certain that they're higher than 630 hours, which is the threshold for eligibility in the SEP program. And so for individuals who are planning to retire and thinking immediately that they're going to substitute, it would be very relevant for them to understand and not have the DRS number be the only number that they will walk away from those meetings with. So
Exactly.
It seems like a really important piece for us to work with DRS on. Tom?
Yeah, I'm glad you brought that up about that CMS rule, because that was one of the things that communication that came to me that we discussed. That was one of the things, and I think it was in the letters of correspondence also. You changed the rules,
Right.
and that you didn't change the rules, but because some school districts were not following the rules, and then they said we got to start following the rules. That's where the idea is that you suddenly change the rules on us. So
Yeah, and I want to be, the districts weren't not following the rules. They were following what was written in our policies and procedures, and our customer service here was providing guidance based on what was written in the policies and procedures. So this is, I don't want to unfairly shift the blame to the school districts on this one. There's many times we can all finger point, but this one is just a significant disconnect here where many people here at the agency believed that we implemented the same way in both programs, and when it came down to the actual writing on the page, it didn't get translated in the same exact way, and so it manifested as a different operational implementation in the sub-program that is, cannot be really squared with federal CMS requirements. So, but I just want to make sure that I'm not trying to blame the districts on this. They were following the guidance that we were giving and had put in writing, and so we're righting that ship. And that's why for weeks I had been saying, like, this isn't a change. And they're like, but it is a change. We're like, well, why do you think it's a change? Oh, because there are people who are waving. And we're like, there are, and there are some. It's a relatively small number, but it's something that really can't be happening.
Dave, I just make one more comment. It's not really relevant to us per se, but it would be to that person who wants to flip back and forth. Another question that might go through their mind is, well, what about Part B? I guess you can, in and out of that. So,
Yeah.
I mean, while it's not our oversight, it's still something that maybe is built into a communication piece at some point.
Yeah, we were thinking that there's probably a true roadmap. Like, if you were doing this, we talked internally about needing to highlight, here's what you could or couldn't do, so people have the information about what to do with Part B, because you're right, you can bounce in and out there. And I want to check in on the phone to see if there's any board members who were there. I just wanted to check out on Michaela and
No, I'm good. Thanks.
Yeah, any additional questions for Dave? Thanks for the heads up, Dave. Next up,
more to come. Thank you.
we're gonna go ahead and vote on the June 27th, 2024 meeting minutes. They're behind tab number 3. Do we have any comments from the board? Hearing none, do I have a motion to approve the minutes as written?
So moved.
Is there a second? So move. All in favor, say aye.
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 Any opposed? Hearing none, the June 27th, 2024 minutes are approved as written. And next up, we have Beth Heston, Procurement Manager in the Herb Division, is going to present some follow-up information from our last meeting regarding Kaiser Washington's end stage rating program for materials behind tab number 4. Welcome, Beth.
Thank you, Chair McDermott. Members of the board, I'm Beth Peston for the record. I am the procurement manager and I'm also one of the Kaiser accountants. So I took the questions that we received last board meeting and tried to sort of build a more logical structure to presenting them back to you. And the first question we had, of course, was why are they introducing this program? And as Dave explained at the last meeting, we have book of business changes that are implemented by the fully insured carriers as part of their business strategy. And this one is in particular a good example of this because Kaiser Permanente National has had a longstanding program around ESRD and getting those folks enrolled in Medicare Parts A and B to reduce their cost shares. Kaiser Washington is introducing this program to align with national. So you'll remember that it's actually, not been forever that Kaiser Washington has been in business. They're the artist formerly known as Group Health Cooperative. And so this is a situation where they've finally come to a time to align with the national book of business.
And Beth, just one thing, because Dave's comments are all ringing in our ears about cost shifting to Medicare, and now that's a big no-no. This is the exception. If it's the exception, this is the time you can do that. So what Dave said minus this.
All right, so Kaiser Washington is introducing this and incentivizing this program to let members get the protection that this will offer them. And that is, the associated Medicare Part D premium costs. So you asked what hurdles ESRD patients face when transitioning to Medicare. Obviously, for everyone, enrolling in Medicare can be challenging. And, someone who is in dialysis and receiving dialysis, it especially causes them problems. So Kaiser has a dedicated member service team who help everybody with transitioning into Medicare. And this would put those folks who have just gotten the diagnosis on end-stage renal disease, who just started dialysis, into that special, into the care of that special group. So, how someone asked last time, how do you identify those patients? How do they become eligible? And this is a place where Kaiser is able to leverage their integrated medical record system and identify claims and encounter data so that they can capture these folks as soon as they start their treatment and the clock starts ticking on that waiting period. So they will reach out to them and it helps also with the prior auth process required for ESRD. Eligible members receive a mailed communication and they're given a dedicated telephone line, and these specially trained representatives guide them through the Medicare enrollment process to expedite it and to answer any questions that the members might have. How does this change benefit them? First of all, it eliminates out-of-pocket cost shares for medical services covered by Medicare Part A and B. And secondly, it allows members more options if they have to seek care outside of Kaiser Permanente. So if they have to go outside of the network, this helps them. Someone asked if it was only for dialysis patients, but no, it's not. This is people who are, active employees who are identified, or existing folks who received the diagnosis. So any member of PEB and SEB who's diagnosed with end-stage renal disease and becomes eligible for Medicare will be, this program will wrap them up and help them. And lastly, the question was, where do they go with questions? And we have a direct member service line number. It's 888-901-4600. And the representatives for Kaiser will direct anyone with questions about end-stage renal disease to that specialized customer service care group to get them started. Are there any questions about what I presented today, or any more follow-up you'd like me to do?
Questions? Beth, thank you very much. Appreciate it. All right, next up, Tanya Duell, our finance manager in FSD, is bringing back 3 2025 PEB non-Medicare premium resolutions for us to vote on today. After Tanya goes over the resolution, we're going to ask for a motion to adopt. A second, we're going to invite the public to comment. We'll do board discussions until we are ready to vote. And we're also going to ask the public, if you're going to comment, please comment specifically about this resolution. We are going to have public comment at the end of the meeting for more general comments. Tab 5, I believe, materials are behind. Tanya, welcome.
Thanks, Chair McDermott, members of the board. For the record, my name is Tanya Duell, and I am going to ask the board to take action on the 2025 non-Medicare employee and retiree premiums. So first up, I had a couple slides on follow-up from the last meeting. So I'm going to walk through that. The first one, Kurt, this was one of the questions you had regarding the premium increases or decreases by the relative tiers. Unfortunately, this is a lot of information and did not fit all on one slide. So this first slide, just to orient you, has the carriers on the left. So Kaiser Northwest, Kaiser Washington, and UMP. And then it shows on the far left, this is subscriber only. You can see I put the tier ratio right under the title there. So this is comparing 2024 to the 2025 proposed employee premiums for that single subscriber rate. And then you'll see the year over year change in terms of dollars and percentages. The next set of numbers is the subscriber and spouse tier, which is a multiplier of 2.0. What you'll see here, if we focus on that first line, so Kaiser Northwest Washington, we'll just focus on that plan for instance, you'll see that the decrease in employee premium for the single subscriber of 142, if you multiply that by 2 for the subscriber and spouse tier, so the tier factor there is 2.0, you get a reduction of $284, so 2 times the single subscriber. You'll notice that the percentage change is the exact same, and that will fall through the remaining 2 tiers because we multiply not only the bid rate, but the employer contribution and the employee contribution by the same tier ratio. So that percentage will fall through each of the tiers. So on the next slide, I have the 2 remaining tiers. So subscriber and children on the left with a tier factor of 1.75. And then on the far right is the subscriber, spouse, state registered domestic partner, and child or children. That full family tier is multiplied by 2.75. And again, if we focus on that first plan, Kaiser Northwest Classic, you'll see that same year over year change of 43% on both of these tiers as well.
Real quick, just back on slide 3, the header that says subscriber and spouse, that also includes state registered domestic partners. So just wanted to acknowledge that too.
The next slide is to answer a question around some of the year over year employee premiums for all of the plans. I've done a bar chart here and separated this by carriers. So on the left, you'll see the Kaiser Northwest plans. In the middle, the Kaiser Washington plans. And on the far right, the Uniform Medical plans. So this is a 5-year look back at the employee premiums for the single subscriber rate. What you'll notice on Kaiser Washington Classic, when you kind of look at them as a whole, you'll see some variability in the year over year premium changes. And that's what we've really focused on with Kaiser, is having more stability in the out years. And that's really where we're focusing some of our efforts for the upcoming years, is around stability. You'll notice that blue bar really stands out for both Washington and Northwest. And that was last year when we had those really difficult conversations around the premium increases for Kaiser. Those are a lot more obvious in the Kaiser Northwest plans you'll see there in the middle of the chart. However, what's a little different here is you'll notice, with the exception of 2024, the remaining years are a little bit more stable for Kaiser Northwest. And again, focusing on stability with the Kaiser products. On the far right, you'll notice on the UMP plans, there was a little bit in the UMP Classic that had some variability starting in 23. That 23 rate increase in the green bar, that darker green bar, was really coming off of the COVID year, where rates through 2020, 21, and 22 had some very small increases, where 23 had a bigger increase than it had had historically, but that is because of our experience rating methodology, where we base on actual claims. And we're looking at historical claims, and that was through that COVID pandemic timeframe when we were experiencing some volatility in our claims. You'll notice in the middle there, this comes back to my talking point from last week, where the UMP Classic rate for 24 actually decreased, and the 25 premium is actually still slightly lower than it was for 23, which I've broken down on the next slide in a little bit better of a view. So if we want to look at UMP Classic specifically on the next slide, you'll notice there's a stacked bar chart here. The total bar represents both the employer contribution and the employee contribution together, with the employee contribution in the gray portion of the bar at the bottom, and then the employer contribution is the blue portion of the bar at the top. It was intentional that I did two slightly different shades of blue in the bar chart for 24 and 25, and this just represents the change in the employer contribution methodology that changed in plan year 24. So as a result of the bargaining agreement effective calendar year 24, the employer contribution methodology switched from a weighted average state index rate methodology to the employer medical contribution, or EMC methodology, for 24. So that caused a little bit of downward pressure on the employee premiums in calendar year 24. And so with the increase in the total bid rate for 25, the employee premium you'll see is just a few dollars less than it was in calendar year 2023. Next piece of follow-up, Harry, you had asked about the pharmacy impacts on the total bid rate increase for UMP Classic. So I went back and I looked at our total year-over-year increase for UMP Classic on the non-Medicare side was a total bid rate increase of 8.1%. However, of that total increase, pharmacy was only responsible for 0.35% of that total 8% increase. And remember, there is a difference in the Medicare structure with how pharmacy and Medicare are structured versus on the employee side. So in total, pharmacy accounts for about 21% of the total bid rate, but this year was responsible for a smaller portion of the overall increase. On the next slide, we did bring back the vision and dental rates that were not included in the last presentation. So as a reminder, for PEB vision, these are 100% employer paid for employees, and non-Medicare retirees enrolled in the non-Medicare risk pool will pay the full vision rate here on the screen. And then we have dental rates, which are paid 100% for employees, and then the early non-Medicare retirees as well as Medicare retirees can purchase dental for these rates here on the screen.
I'm gonna jump in, Tanya, because there was a second question. So we usually do bring these premiums, and they were omitted at last meeting's slide deck because we were still finalizing something with the vision plans. We could have brought the dental, but we usually keep it on one slide. So we do bring you the rates. The other question that came was, is there a vote on these rates specifically for the non-Medicare and Medicare retirees who can enroll in them? And so dug back into this, I said, hey, we all kind of have different recollections on some of this. We've always shown the rates. We looked through the record of resolutions that we have, and it went back to 1995, and there's never been a vote on the dental rates. And the reason that we can identify that as to kind of the logic as to why they aren't brought forward is, we'll just use dental right now because this is the classic, the vision is new for this year, but it's the same logic. These rates represent a single rating of all of the possible enrollees, whether it's employees, whether it's non-Medicare retirees or retirees. And so it's a single rate for that entire population. And the board doesn't have the ability or authority to reject an employer contribution. And if we were to parse out and have you vote on a piece, on the retiree piece, and you said no, then we'd have to go back and re-rate with just the employees, and we wouldn't have an employee-based plan that is fully employer paid. So because of how things are rated together, and there's not the authority to reject a fully paid employer contribution piece of the puzzle, we have never brought for a vote the rates independently. So it's a little bit of convoluted logic there. It might be a little, if you need to say it again, I can try to say it again, but it's really related to the fact that they are single community rated for all parts of the population. And the board doesn't have the authority to reject the employer paid benefit that is offered to the employees, which is inherent to the rates that you see on the page today. Harry.
Thank you for the update. I think it's important to continue to show this because after we've gone through the medical and people focus in on that and then employees and lose sight of that they also get dental benefit and pharmacy benefit, prescription, vision benefit that is being paid by the employer. So I think it's important, again, to get the full context of that. I recall a couple of years ago, we did talk in quite a bit of detail about the dental benefit, about whether to enhance it in some way, which would have then somehow impacted back on the medical side because of that ability to give and take on the benefits. If you want to enhance one thing, you have to give up something else. In other words, keep it a balance. So thank you for bringing this forward. Appreciate it.
Yeah, and we definitely always plan to bring them. They weren't baked enough to bring last meeting. And since there aren't resolutions related to them, we figured we could bring it to the last meeting. But we will always bring these. We have and we will continue to show them. Elliot?
Yeah, this is probably an obvious question, but I've always been curious about it. So the state negotiates the employer premium with the unions. Is that? No.
For employees, what is negotiated as part of the collective bargaining process is the percentage split only. So the EMC methodology that we've walked through earlier this year, where the state contributes 85% of a benchmark plan, that is what's defined in the collective bargaining agreement, not the actual dollar value. Same with vision and dental. It states in the collective bargaining agreement that the state will pay 100% of the total cost, but the total cost is not mentioned as part of the bargaining agreement. So it's just about the split that the state paid for, how much as a percentage.
Okay, thank you. That's very helpful.
Yes, and then we do the negotiating with the carriers on the total dollar value, and then we apply that percentage to it, which in vision and dental is 100%.
That really helps to know about the bargaining process because I've never quite understood it.
This may have been answered a couple of weeks ago, and I apologize, but forgot. But getting back to the UMP plans, you talked good information regarding the classic and why it's kind of stabilized for this year.
Mm-hmm.
Yet the others are so relatively significantly higher, yet they're the same PPO, the same, all that. Why would, in particular, the plus plan increase so significantly relative to the class?
So the plus plans are a narrow network. They're comprised of two smaller narrow hospital systems, right? Two very narrow networks. And when we develop rates, we develop the rates based on the actual claims experience and risk for those plans specifically. And for this year, for the first time, the plus plans are outpacing the UMP Classic. So the UMP Classic is really, a big statewide system. So those narrow network plans that are experiencing different utilization and unit cost patterns and increases we bake the rates based on that plan specific experience. And this year, it is outpacing Classic. It still has, the UMP Plus does have a richer benefit than UMP Classic with the lower deductible and the free cost sharing for primary care visits.
And
So members will.
and the prescription deductible that doesn't exist here.
Yes, so this year, members will need to make a decision based on their own utilization patterns and how they, experience healthcare, and whether they want to switch to maybe UMP Classic, or if they are maybe, utilizing their services, if it's more cost effective to benefit from the lower deductible and those cost sharing, the free cost sharing that they don't have in UMP Classic.
Thank you. It seems to me years ago when 7, 8 years ago, I guess it's been that long since we chose to started the UMP Plus, that's what I'm trying to say. A lot of that discussion was value network, that it would help contain costs, that you get, actuarial value could it proved to be significantly really good. And so just wondering if it's kind of catching up with us now, or that some of the original concepts, expectations from that are now kind of turning in the opposite direction. If that makes any sense. I hope it does.
Yeah, it does. It makes sense. It is still a value-based arrangement where there's a shared savings arrangement between us and the networks, where there's an upside downside risk arrangement. And we are still in that and finding, some value in that shared savings arrangement. The costs of some of that are baked into the rates. But really what's driving the increase is the higher utilization and the increased enrollment in those plans. Anything you want to add?
I was going to add, I already forgot, was there something you were gonna add? I was just gonna.
The contracts aren't as favorable as when we originally set the contracts, because as you get near the end of the contract and you're trying to renegotiate, leverage starts moving around the table. So we had all the leverage in the beginning, and then we have lost some of that leverage over time.
And the piece that I was thinking of and then forgot is some of the financial arrangements really kind of cap when there's high cost claimants, the risk that there's only so much risk that is borne by the network, but the plan still has the risk of the high claimants. And there were, in the most recent experience, a few more high cost claimants that has typically existed. And so that is all borne in the plan, but some of that risk isn't fully shared with the networks. Tom, yes, sorry.
Don't have my hand raised electronically.
You have a green light, so.
So this is kind of going back a little over a year ago when we were having that discussion. Oh, can you go back to, I'm sorry, can you go back to slide 5? So during the course of that conversation, discussion about Kaiser Permanente and maybe their motives for doing things. I remember one or several people suggested that maybe this was these extremely high rates that they were going to was an attempt to get the sickest people out of the system, and the healthy people would remain. Now you look at this year's rates and how much less they are, but I also heard, and this is where the question comes in, is that did the opposite. The healthy people were the ones that left to seek lower rates in other plans, and the people who were less healthy were the ones that remained in the Kaiser plan. I was just more or less curious about all of that and how that played out.
So Tom, I can't speak to necessarily Kaiser's motives to get rid of the sicker people, because I'm unsure, on that piece. But what I can tell you is what happened is that they did retain the more sick, the higher risk score members, and some of those healthier members were the ones who made the switch out of Kaiser. I can also say that new employees, where the younger, more healthy employees, are not choosing to enroll in Kaiser. They are choosing other plans also. So that is all having impacts on their overall risk scores.
And when you think about it, as people were entering open enrollment last year, if you think think about it, it kind of makes a logical sense. If you're somebody who's undergoing a comprehensive treatment, you're less likely to upset, that treatment plan and just kind of stay the course and make sure that you're getting the treatment and you're on a path. If you're healthy and invincible, minded, and you're looking around, you're like, maybe it's now the time to look elsewhere. And then as Tanya said, people who are new to the portfolio and picking for the first time don't have any context of what premiums were 1 to 5 years ago. And so they're just looking at fresh and going, okay, I feel young and invincible. I'm going to go here. Not that all new employees are young, but many of them think they're invincible anyway.
Yeah, with the employee premium stabilizing a bit more for 25, it's unclear if that dynamic will stay for 25 or if some of the new employees will then go back and start choosing the Kaiser plans just based on premium.
If I could just jump in here, it seems to me the, Tom is saying, or we're hearing really happen, then the rates would continue to go up and not go down. In other words, if the sick people, so to speak, I don't like to use that term, but the ones with higher utilization or greater claims chose to stay, then the rates would likely continue to go up. I mean, or maybe they made a mistake or, I don't want to go down that road, but I don't think it's because those who were high claim users chose to stay, because then the rates would not go down like they did. It just.
So Harry, we
Would
talked
make
about
sense.
this briefly earlier in the year, and the bid rates do not reflect the risk of those members being baked into the bid rates. The bid rates are based on a 1.0 risk score for the whole population. So there's a difference between a payment rate and a bid rate, and the leveraging effect that the risk score has on the bid rate. When a risk score goes up higher, the bid rate actually comes down a bit. So that's why we're experiencing decreases in employee premiums, whereas the overall revenue that the carrier might need could go up.
I think it's important just to remind everyone that our overall methodology for financing the portfolio is to try to normalize some of the effects that might happen by premiums perfectly reflecting the actual risk of those individuals in the plan, because you would see a lot more running to and from plans year over year. You'd see a lot more volatility. So a lot of the levers that are in the financial modeling are to try to normalize the premiums, normalize that effect to some extent, so that you're not having healthy people or lower utilizers chase a different plan year over year. So we purposefully make adjustments from what is actually paid to the carriers to try to mitigate some of that what would be adverse selection.
So we pay the carriers for the risk of the plan, but we don't penalize employees for enrolling in a plan with a higher risk score. Or else employees would never enroll in, let's say, UMP Classic. Or
there'd be certain plans that
Yes.
they would never likely enroll in.
And just a quick comment, we're about a half hour over, and based on yesterday's meeting, the last presentation is going to evoke a lot of questions. And so I don't know if people's schedules on the back end, the consolidation discussion will.
Well, I'm going to save you one slide because one accidentally got put in your briefing book that didn't need to be. So we're going to skip over.
Nothing changed.
Nothing changed. We're going to go straight to the Kaiser slide here. So this is really just a formality. You don't usually see benefit changes in my presentation. It came in late last board meeting, so Beth didn't have the full slide in her presentation. So we're just formalizing it in my presentation, but Beth spoke to it verbally at the last meeting. And this is just about Kaiser Northwest and Kaiser Washington and their contract ending with My Strength. They are going to communicate with members, and members will have other options to enroll in. So next up is just a reminder of the employee premiums, which I think we've already talked through a bit. So if there's any further questions on employee premiums, I can take those now. And then 2 slides forward, we have a reminder of the non-Medicare retiree premiums. And as a reminder, these are just based on the total bid rate that we set for employees, plus an administrative charge. And then I'm going to turn it over to Chair McDermott to walk through each of the resolutions. As a reminder, each of the resolutions are set up by carrier. So by the board authorizing each carrier resolution, you're authorizing the premium and the benefit design for each of the plans that carrier is offering. So Chair McDermott, turning it over to you.
Yeah, any additional questions? All right, here we go. Resolution PEB 2024-28, resolved that the PEB board authorizes the Kaiser Foundation Health Plan of Northwest employee and non-Medicare retiree premiums. Is there a motion to adopt?
So moved.
Is there a second?
I'll second that.
Any comments from the public? Seeing none, any comments from the board? Is that a preparatory press? Gotcha. It's going to be a roll call vote, starting with Harry.
Aye.
Tom.
Yes.
Sharon.
Aye.
Elliot.
Aye.
Kurt.
Aye.
Michaela.
Aye.
And Lou. Yes. Resolution 2024-28 passes. All right. Next up, we're going to vote on resolution PEB 2024-29. Resolved that the PEB board authorizes the Kaiser Foundation Health Plan of Washington employee and non-Medicare retiree premiums. Is there a motion to adopt?
So move.
Second.
Second.
Any comments from the public? Seeing none. Any comments from the board? Seeing none. Roll call vote starting with Harry. Aye. Tom.
Yes.
Sharon.
Aye.
Elliot.
Aye.
Kurt. You might.
And aye.
There you go. That's all right. Michaela.
Aye.
And Lou, yes. Resolution 2024-29 passes. Next up, resolution PEB 2024-30, resolved that the PEB authorizes uniform medical plan, employee and non-Medicare retiree premiums. Is there a motion to adopt?
So moved.
Is there a second?
Second.
Any comments from the public? Seeing none, any comments from the board? Voting starting with Harry. Aye. Tom.
Yes.
Sharon.
Aye.
Elliot.
Aye.
Kurt.
Aye.
One more time, Kurt.
Aye.
There you go, bud. All right. Michaela.
Aye.
And Lou, yes. Resolution 2024-30 passes. Tanya, thank you so much. Next up, we have Molly Christie, financial analyst in FSD, is going to be presenting the 2025 PEB Medicare premium resolutions for us to vote on today. Her materials behind tab number 6. Welcome, Molly.
Good morning. Thank you, Chair McDermott and members of the board. I am returning today to present the 2024 Medicare premium resolutions for action. The next slide. So, the slide after this reflects the 2025 Medicare retiree premiums proposed for action by the board today. These have not changed from what I presented at the last meeting. As a reminder, these premiums, excuse me, are already reduced by the Medicare explicit subsidy, and they include the benefit changes previously discussed. Ellen went into detail on that at the last board meeting. As a reminder, UMP and the Kaiser Northwest and Kaiser Washington plans include Medicare Part D prescription drug coverage. And I want to open up to questions if the board has any remaining questions about these rates before I transition to Lou or Chair McDermott, excuse me, for the resolutions.
We've known each other. Do we have any questions? Thank you, Molly. We're going to go ahead and vote on resolution PEB 2024-31. Resolved, the PEB board authorizes the calendar year 2025 monthly Medicare explicit subsidy of $183 or 50% of the premium, whichever is less. Is there a motion to adopt?
So moved.
And a second? Second. Any comments from the public? Seeing none, any comments from the board? Voting starting with Harry. Aye. Tom.
Aye.
Sharon,
Aye.
Elliot,
Aye.
Kurt,
Aye.
Michaela.
Aye.
Yes, resolution 2024-31 passes. Next up, resolution PEB 32. Resolved that the PEB board authorizes the Kaiser Foundation Health Plan of Northwest Senior Advantage with Part D premium. Is there a motion to adopt?
So moved.
And a second.
Second.
Any comments from the public? Seeing none, any comments from the board? This will be a vote starting with Harry.
Aye.
Tom,
Yes.
Sharon,
Aye.
Elliot,
Aye.
Kurt,
Aye.
Michaela,
Aye.
and Lou, yes. Resolution 2024-32 passes. Next up, resolution PEB 2024-33. Resolved, the PEB board authorizes the Kaiser Foundation Health Plan of Washington Medicare Advantage with Part D premium. Is there a motion to adopt?
So moved.
Thank you. Is there a second?
Second.
Awesome. Any comments from the public? Seeing none, any comments from the board? Voting starting with Harry.
Aye.
Tom?
Affirmative.
It's okay. Sharon?
Aye.
Elliot?
Aye.
Kurt?
Aye.
Michaela?
Aye.
And Lou, affirmative. I like that. Resolution 2024-33 passes. Next up, resolution PEB 2024-34. Resolved that the PEB board authorizes the United Healthcare Medicare Advantage with Part D premiums. Is there a motion to adopt?
Yes.
Is there a second?
Second.
Any comments from the public? Seeing none, any comments from the board? Roll call vote starting with Harry.
Aye.
Tom,
Yes.
Sharon,
Aye.
Elliot,
Aye.
Kurt,
Aye.
Skylar,
Aye.
and Lou, yes. Resolution 2024-34 passes. Next up, resolution PEB 2024-35. Resolved that the PEB board authorizes the Premera Medicare supplement premiums. Is there a motion to adopt?
So moved.
Is there a second?
Aye. Oh, yes.
There you go. Any comments from the public? Seeing none, any comments from the board? Voting starting with Harry.
Aye.
Tom,
Yes.
Sharon.
Aye.
Elliot,
Affirmative.
Kurt,
Aye.
Michaela.
Aye.
You all right there, Michaela?
Yes.
Okay, okay. And Lou, yes. Resolution 2024-35 passes. All right. Resolution PEB 2024-36. Resolved that the PEB board authorizes Uniform Medical Plan Classic Medicare with Part D premium.
So moved.
Is there a second?
Second.
Any comments from the public? Any comments from the board? I just want to say this is a long time coming. Vote starting with Harry.
Aye.
Tom,
That would be a big affirmative.
Sharon,
Aye.
Elliot,
Enthusiastic affirmative.
Kurt. One more time, Kurt.
Are you having a hard time hearing me? I'm sorry.
We did, it cuts out a little bit. I just want to make sure.
Okay.
your vote
It's
correct.
yes. Yes, affirmative. Aye.
You only get one vote, Kurt, I'm sorry. Michaela,
Aye.
better. I like that. And Lou, yes, resolution 2024-36 passes. Thank you, Molly. Appreciate all the work.
I just want to say, we've caught up a lot of time, so that's great. But remember the public who might be the first time that they're chiming in, that may feel like it was a very fast process. we recognize there's a lot of work that goes behind this. There's been a lot of conversations, especially on UMP Classic Medicare since January, actually February 1st, because the retreat was February this year. And I know that the board realizes the amount of work that gets to a point where you can do rapid succession vote-orama, if you will. But there's a lot of work that a lot of people did behind it, and that's a great transition for Chair McDermott to get us over to Ellen. But just wanted to make sure the public knew that, yes, that was the formal voting process. There was a lot of discussion before today that got to that.
And I think it's fair to say when that does not go smoothly and when there is a lot of comment and the board has a lot of discussion, it's like then we haven't really beat that horse to death yet. There was more work to do on that. So I do appreciate all the conversations that went into that. And speaking of conversations, Ellen Wolfhagen is coming to give her last presentation to the PEB board. She is the retiree benefits manager in HER, and her materials are on tab number 7. Ellen, take your time. Enjoy it. Roll around in a little bit.
I actually have a question / comment before you start.
Before you even start, fire away.
I want to say thank you for this part about the myths, because that is one thing that people have much anxiety about, and this really speaks to most of the things they have that anxiety about. So that's a great addition to have to this presentation.
Well, I think probably the hundreds of conversations you've had with retirees, you've developed a bucket list of myths that you have to debunk each time. And yeah, appreciate it. Floor is yours.
Thank you so much, Chair McDermott, members of the board. I'd like to just take a minute to say how much I've enjoyed all these past months preparing presentations, interacting with everybody on the board, interacting with the groups that you represent. This really has been the highlight of my career, and I appreciate it. So with that, the presentation topics today are those myths about UMP Classic Medicare and Part D. And then I'm going to give you an update on what we're doing for the implementation status and a review of the communications timeline. Next slide. So some of the classic myths that I hear are I need to sign up with Medicare or I'll be subject to a late enrollment penalty. I hear my drugs will no longer be covered, which frankly mystifies me. I have to pay separately for Part D coverage and will pay more for my drugs, and I won't be able to see what drugs are actually included in the Part D formulary. And that myth is directly related to Elliot's. There's a secret cabal about what's included in the drug list. So I'm going to talk about the availability of the drug list in just a second. Next slide, please. So in terms of signing up with Medicare, there's a question about, I'll need to sign up in addition to what I'm doing with UMP Classic with Part D. The facts are enrolling in UMP Classic Medicare enrolls you in the Part D plan. You do not need to contact Medicare. You don't need to do anything else about it. And as long as you have had creditable drug coverage, such as with UMP Classic Medicare up until December 31st, 2024, you will not have to pay a late enrollment penalty. And a late enrollment penalty applies only if there has been a gap in coverage of more than 63 continuous days. So in most cases, nobody will have that. Myth number 2, next slide, please. My drugs will no longer be covered. So this is a direct quote I heard from somebody. I told my pharmacist that UMP was my plan and it was changing to Part D, and the response was, oh no, you won't be able to afford the copays and your drugs will no longer be covered. And I thought, I find that a little mystifying. I am surprised a pharmacist would say that, but in any case, this is a commercial, this is an employer group waiver plan, very different than a commercial Part D plan. So there could be instances in a Part D plan where somebody would pay more than they currently pay on UMP, but not with our Part D plan that is embedded in UMP Classic Medicare. So our copays in most instances will be less, and virtually all drugs currently on UMP will be covered. And to the point of the secret drug list, the drug list is available. The current drug list is available on the public website. And the citation is rather long, unfortunately, is hca.wa.gov/assets/PEBB/preferred-drug-list.pdf. So it's a PDF file. If people can't print it out, they could request that we provide it, but in most cases, people can just go to the web and print out that. Anybody in the public, you don't have to be a member of UMP to get that. That is the current PDL. Once the formulary for Part D is approved, the list will also be available, and exactly where will be announced when it's available.
Real quick, if I remember right, at the last board meeting, in my follow-up slide at the very beginning, there were a couple of hyperlinks that went to various resources, and one of them was PDF for the preferred drug list. So if you didn't capture in real time Ellen's verbal hyperlink, you can go back to the immediately preceding board meeting materials and look in the early part of the briefing book that's on our HCA website for PEB meetings and materials and be able to access that link.
Thank you. Next slide, please. So there's a lot of confusion about switching to Part D and the requirement that you have to pay separately for Part D than you do right now. And it is very important. The premium for UMP Classic Medicare includes the premium for Part D. There is no separate premium. It's a reduced cost overall, and it covers Part D. And again, copays are generally less under Part D, except for specialty drugs, which may be higher in some instances. And the lower UMP Classic Medicare premiums and lower copays overall will net out to overall savings for the year. Next slide, please. So myth number 4 is I won't be able to see what drugs are actually included in the Part D formulary. This is a corollary to Elliot's secret list of drugs that nobody knows are available.
Thank you.
So it is in fact not a secret list. And again, the Part D formulary has to be approved, will be posted on the MODA website in early September. The tiers are defined by CMS, and the tiers are generally defined by generics, preferred brand name drugs, non-preferred drugs, and specialty drugs. And that concludes, oh no, one more. Nope, that was it. Okay, so in terms of the implementation, as a reminder, we will automatically migrate current UMP Classic Medicare members into the plan with Part D. So no form or action by a current enrollee is needed if they want to stay in the plan. However, members can change plans, they can enroll in UMP Classic Medicare for the first time, or they could come back to UMP Classic Medicare. In those cases, they would have to fill out a form. Members who need to make certain changes on their accounts can use benefits 24/7 to add or drop dependents and add or drop dental coverage. Just a reminder, with all the discussion of PEB and vision benefits, vision is covered under the medical part for all Medicare plans. That's why it's not listed here.
And I just want to reinforce that no action or form or online enrollment is needed for anyone who is not making any change to their account and is in UMP Classic today and wants to be in UMP Classic with Part D tomorrow. In fact, I'd encourage people not to submit something if they just are kind of status quo and want to stay in the new, slightly different version of UMP Classic. Because if we had 38,000 forms come in to say, I just want to be where I am today, tomorrow, it is going to delay all of the enrollment processes for everyone who is actually making changes in their account and have to be documented and processed. So we really are going to try to push that message of, you do not need to take action if you're there today, not making other changes in your account and want to be there tomorrow. We will put you there. it will actually, we're not changing our staffing levels. We're not hiring additional part-time staff for a potential influx of 38,000 unnecessary forms. So just, it's a really important message that if there's nothing that you're changing about your account and you're in UMP Classic Medicare today and you want to be in UMP Classic Medicare Part D tomorrow, just do nothing.
Thank you. Next slide, please. So in September, letters will go to current UMP Classic Medicare subscribers, and the MODA drug lookup tool and pricing tools will be available on the MODA website. In October, there'll be additional letters to specific UMP subscribers who need to make address changes to be in compliance with CMS rules. MODA customer service will be available to answer questions, and that will happen in early October. Next slide, please. And continuing with October, the customized retiree letter that many of you are familiar with will be issued. That includes the premiums and alternative plans that are available. The retiree-specific open enrollment webpage will be updated. This is something that we put into place last year and was very useful to have a specific page for just retirees to look at. Anybody could look at it, but for retiree information, the UMP Virtual Benefits Fair webpage will be updated. The retiree newsletter will be issued. October is a very busy month for us. Updated retiree open enrollment packets will become available. And just a reminder, open enrollment begins October 28th this year. And then in November, open enrollment ends November 25th. And as always, we must receive forms by that date. So anything that is sent in must be received by November 25th. With that, thank you so much for your attention over these past couple of years.
They don't get away that easily, Ellen. We just want to, I want to make sure to say publicly how much we thank you. You know, there's been, I say Ellen has been a guest star at the SEPORBs, but she's been a series regular for seasons, multiple seasons, and had a long story arc here at the PEB board with a lot of work in the Medicare portfolio. And we've learned over the recent years that I think the phrase that I remember is Ellen's very user-friendly to our retiree community, and we appreciate all of the work that she has done with the outreach and the collaborative efforts to shore up and rebuild trust with the retiree community. She was a critical part of that alongside of our just general work here at the agency, but Ellen was a key part of that work in the past couple of years. So, you know, she will still be here for open enrollment this season, but by the time we return for the board retreat, Ellen will have retired. And so this will be her last piece here, but really appreciate all that she has done. Again, I know many retirees have been able to relate and find comfort in how Ellen has been able to describe things, and she's been a very strong voice for helping bust myths. I can't say that phrase. It's so hard for me. Myth busting is just a phrase I can't say. She's the way she thinks about things and says, "Hey, let's present it this way," has really resonated with people, and just really appreciate her work in this area.
Should we sing happy birthday to her or something? Kind of chairs.
No.
It's not her birthday.
It was last week.
Ellen, you know, I think I'm remembering back to some of my conversations with Dave. We were talking about the retiree population and how our agency interacts with them. And the fact was we didn't have dedicated resources specifically for that. We had generalists. And when you came in and started doing that specifically, it made a huge difference, which, you know, now that we think back, it's like, yeah, you put resources towards something and it gets done and it gets done well. And so really appreciate your professionalism, your knowledge, the way you interact with the public, the way you interact internally. I know Sue always called you the superstar, the retiree superstar, and it's very much appreciated. And I hope this is the last we're going to hear to you, because public comment, you're going to be in the public and you're going to have some comments. Just try not to use too much inside baseball on us. Other board members?
Yeah. hate to waste everybody's time, but a year ago, I was really cautiously optimistic that we could actually be at this point. So I want to acknowledge and congratulate everyone for their tireless efforts to make Part D a reality. And so thanks to the leadership of the Healthcare Authority, thanks to Dave, ERB leadership, especially Ellen, Ryan, Luke, and also our partners, Moda, Milliman, whoever else I may have forgotten, and also the board. And most importantly, the retiree community, whether it's the individuals who come in here or those who are representative of groups such as RPEC, who really provide the spark and have been fully engaged in this process. So we can celebrate for a short time. Don't take our eye off the ball. There's more work to be done. So, but personally, thank you, Ellen. It's been a real pleasure getting to be schooled, if I say, in a positive way from you and the rest of the staff. Thanks again.
Chairman, I might recommend, I think there are a few members of the public that also want to thank Ellen publicly, and it might be a point of personal privilege to just allow a few public comments if they're germane to thanking Ellen. Now.
Absolutely. So the resolution is to thank Ellen, and we're open for public comment on that particular issue. Do we have members of the public?
Yes, this is Fred Yancey. Can you hear me?
Yes, sir.
I said this yesterday, and I will say it again. Just a great thank you to Ellen. She's made a great difference to the retirement community in terms of her professionalism and her clarity, and we certainly appreciate it. I've got to go. There's a phone ringing in the background, but Ellen, thank you.
Well, Teams blocked it out. We're still in whichever one we're on. Annette?
Yes, my name is Annette Barca. I am a WA retired member as well as a Sheba volunteer. So this may be why some of my questions are what they are. I have several questions. First question is, I'm glad that the drug plan will be available for people to take a look at and find out if their medications are covered with the new Part D plan as part of the Uniform Medical Plan. But I'm wondering if in that process, is it going to continue to be one drug at a time that you have to look up, or will there be a process whereby I can look up drugs similar to the way it's done right now on the Medicare's Plan Finder, where I can find the cost of all my drugs collectively?
Ellen, you're on the hook for that one.
We'll have to follow up on that because I know that we'll take that as a note for Ellen to follow up with you on, Annette. So she'll have the assignment. I don't know that we know that sitting here right there here today.
I think we said we'll get back to you on that one. Do you have other comments about Ellen or other questions? All right, thank you. Do we have others?
I have another concern. My biggest concern is I do retirement seminars as part of the group that was mentioned earlier in your meeting around the state for school employees that are looking at retirement. And one of the things that I am really concerned about the change that is occurring this year are the dates for open enrollment. Not so much for the people who are newly retiring this year, but for the people who've been retired for a number of years and have relied on being able to make changes clear through the end of November. And I'm hoping that there's going to be multiple, maybe even within various documents, various places where it's repeated again and again so they can't forget or say they didn't see it. The fact that it's going to, not so much that it starts on October 28th, but that it ends on November 25th this year, and that it's understood that this date is a moving date from one year to the next based on when is the last Monday in October and the Monday before Thanksgiving. So how is that going to be addressed to reinforce the fact? All too often, I find, at least as a Sheba volunteer, I have spent the time after Thanksgiving with numerous PEBB people in the area where I live, Whidbey Island, making sure they've got everything done and in place by the end of November, because they come to rely that this is when they can do it, and make sure they have the maximum time to make their decision.
And that there will be extensive, we have had open enrollment for decades, be the entire month of November, and we recognize that this is a shift that will require many bold sentences and a lot of letters on postcards as we get into open enrollment season. It's why we started advertising it to retiree communities in May to begin the process of helping people understand. We realize that this is a shift from November 30th to a date that's not November 30th. It will be plastered in many places.
All right.
Okay, because yes, I just don't want somebody to get messed up because of timelines.
Appreciate that. And that one got by the goalie. We're gonna try and limit this public comment to any comments related directly to Ellen and her departure from HCA here at the end of the season.
Because we will have public comment at the end.
We will have public comment at the end. Yes, Mackenzie. Next. Aruna.
Aruna Bhuta from Spokane. Thank you for this opportunity. We wish Ellen happy retirement, and thank you very much for, making Medicare, enrollment in various plans more understandable for retirees, because it does become very complex as we get older to deal with all these different plans and how to make the decision. So continued efforts in that direction by Ellen, and also for the person who comes next after her, would be greatly appreciated. But thank you, Ellen, for all your hard work.
Thank you, Aruna. I appreciate that.
Next up. Christine Clark. You're still on mute. Christine Clark.
Okay, now next is Ann Monroe.
Ann Monroe. Ann, are you available?
I am. On behalf of the WSU retirees, I'm the benefits director here at WSU, and myself and staff. We will so very much miss Ellen. She's been a fantastic resource to us personally in our professional relationship, and to our retirees. She's always been so accommodating whenever I've contacted her. She will be sorely missed. And the other thing I hope, and it kind of mirrors one of the past comments, is I hope she's giving you enough time that you can clone her, and we've got a great replacement in place to take over her role when she leads, because that'll be a big pair of shoes for someone to fill. So Ellen, thank you so much, and I wish you nothing but the best in your retirement.
Thank you, Ann. I appreciate that.
And with regards to cloning, we are at least duplicating the position and hiring somebody to overlap to have as much experience with Ellen. We haven't quite got true cloning technologies down yet. And we did receive another resource as part of the supplemental operating package budget that we are expanding and adding another member to have a little team of future Ellen proteges going forward. So expanding that resource commitment to this part of our work.
And I think cloning is still considered experimental, so not covered. Sean, is that correct?
Yes.
He's like, damn right, we're not paying for that. More members from the public.
Christine left and rejoined.
Christy, you want to give another shot?
Yes, hi, this is Christine Clark. Both my spouse and I sent questions to Ellen, and we were very satisfied with the response we got. Thank you so much.
Outstanding. Any others? Ellen, thank you so much. You're out of the hot seat. You're like, just get me out of here. Why don't we all take a 10-minute break? It is 10:31. Let's come back at 10:41. Yes.
We're covering it.
All right, we're back in action.
Only a lawyer would ask for the packet, right?
Next up, we have Alyssa Richards, Benefit Account Section Manager, and Herb is going to present some information regarding preparation efforts for the PEB program open enrollment this fall. Her materials are behind tab number 8. Alyssa, how you doing?
I'm great. Thank you. Good morning, Chair McDermott and members of the board. For the record, my name is Alyssa Richards and I'm the Benefits Account Section Manager. So I'm here today to give you a preview of the open enrollment strategies that we've been working on. So if you can go to the next slide, please. Open enrollment plan activities typically start months before open enrollment begins. Many of the divisions within Healthcare Authority work together to plan for a successful open enrollment. As we've shared previously, open enrollment dates for PEB have changed for this year. Open enrollment will be Monday, October 28th through Monday, November 25th at 11:59 p.m. So any forms will need to be received by that time. In March, we begin meeting with the various areas of Healthcare Authority to discuss open enrollment tasks that are needed to be completed. These planning tasks include communications materials, planning for enrollment system updates, etc. And then starting in April, the planning begins for benefits fairs. The outreach and training team facilitates these discussions and they start planning for the number of fairs, the locations based on member feedback and enrollment information, and then securing the venues for the fairs and working with internal staff to plan for support on site for each of those fairs. And then in June, the PEBB communications team starts drafting the communication materials for the open enrollment period. And then in July, today, the board votes on premiums, which kicks off the ability for us to finalize some of those materials for open enrollment. August, our HCA finance and communications team finalized the rate sheets and the communications plan gets finalized. And then October is very busy as we start to send out newsletters with open enrollment information. The open enrollment website with materials is published. And then, of course, open enrollment begins October 28th. So
Alyssa, I just want to jump in. One of the pieces that, I know this board realizes that today's the last board meeting for this board season. It's much earlier in July than we typically have ever been. And one of the reasons is there are so many different pieces that are changing that the extra time to be able to check things that get rolled into the IT system, additional communications that are planned. There's so many different moving parts this year with Part D, with Vision, with the change of the open enrollment date, that this extra couple of weeks is really helpful from an operational standpoint. So really glad that just the way the rate negotiation process went this season allowed us to expedite the rate process that usually goes a couple more weeks into July, but just it really ties together our pivot. We pivot literally tomorrow to many of the finalization process so that we can begin reviewing and integrating things that cascade out of rate books and into rate sheets and into various publications. So we are ready to pounce after we celebrate today, finalizing board season. But it's really cannot be underestimated. The thank you to everyone internally and to the board for having the board season as a little earlier. So back to you, Alyssa.
thank you. All right, next slide, please. So as I mentioned, the open enrollment dates have changed for this year, and this change in dates was made based on feedback we've received, which includes having available support when the last day of open enrollment falls over the long Thanksgiving holiday. And this year in particular, November 30th falls after that Saturday after Thanksgiving, and so there's no support available during that time. So it was also decided so that we could provide additional time for the post-open enrollment work that has to be done, like manually entering changes from paper forms, the file exchange with carriers, and then timely mailing of carrier welcome packets. And one of the other key reasons for the date change is based on the data showing higher engagement during open enrollment on a Monday.
Yeah, I'll just add this because this is something that I've been listening to feedback for almost my entire duration as the director of the division and watching the calendar closely for when it became the perfect storm of Thanksgiving being laid on the 30th on a weekend, because we do see year over year in the data that when Thanksgiving falls as it does and the last day of the month falls in the post-Thanksgiving area where there's no no ability to communicate with people, we see more appeals. In general, we have a third of enrollments that happen in the first 48 hours of open enrollment, a third of enrollments that happen in the last 48 hours of open enrollment, and a third in all the days between, regardless of how many days are between. So we see a concentration at the beginning and end, and when people can't access customer support, it really just manifests as appeals, and that's not where anybody's energy is, the least of all helpful to the actual member who's trying to have coverage and understand what that coverage is on January 1st. So now that we are facing a calendar that looks with Thanksgiving this way, we're just permanently moving the open enrollment to end the Monday before Thanksgiving. So it will be a floating day, but it will always be the Monday before Thanksgiving. So that's the permanent shift we're working on. It also are the dates that we have been using for SEB since the launch of the SEB program. So there is at least some familiarity for the K-12 population who's retiring to have some experience with an earlier date. But it really stems from hearing from some of the higher education institutions who I believe some of the feedback I heard in the early days was they would draw straws for who would come in on the Thanksgiving weekend and would actually staff over the Thanksgiving weekend so that university employees could turn in forms or ask questions. And that just never sat right with me, that we're supporting a system that doesn't have universal access to customer service at that time. And then really, when I hear people drawing lots as to like having to work over a holiday weekend, that's a traditional time when the state workforce is not working, it just never sat right with me. So I know this represents kind of a seismic shift. I think if I look back in the records, we've had the month of November since at least the early 90s. So it is a big shift mentality. But there were some very solid reasons why we're making this shift. I just wanted to make sure to highlight them with a little bit more emphasis.
Thanks, Dave. Okay, next slide, please. So the allergen training team works directly with PEB organizations, benefit administrators, and they support over 700 PEB agencies and SEB organizations. They provide the training to organizations regarding program plan options, covered benefits, eligibility, rules, and enrollment processes. And then in turn, those organizations act as the first line of customer service for their employees. And when benefit administrators need assistance, they reach out to outreach and training for support, either by calling our toll-free line or sending a secure message through HCA support. The team works on open enrollment year-round for strategies and process improvements, and we use member feedback to help with those planning activities. This year, I also wanted to note that the outreach and training team has been very busy fielding inquiries from benefit administrators related to benefits 24/7. They've been working diligently to respond to tickets as quick as possible and escalating some of those bugs as they're identified to the benefits 24/7 IT team. So a little different than years past. We're going into this year trying to get through that stuff quickly. All right, next slide. The customer service unit is the first line of contact for retirees and continuation coverage enrollees. Staff perform 3 primary functions. They answer calls via a toll-free line and respond to HCA support inquiries. They provide in-person lobby services for walk-in members, which during open enrollment is very busy. People appreciate that face-to-face contact. And then review members' retiree or continuation coverage eligibility as they process the enrollment forms. This year, we have 27 filled medical assistant specialist 3 positions, which are all of our funded positions. They're all currently filled, and all Mass 3 staff will be fully trained by the start of open enrollment. So next slide, please. Okay, so every year the Outreach and Training Unit conducts webinars for the benefit administrators to help prepare them for open enrollment. These webinars will be recorded and then later posted on the benefit administrators training webpage. Once those dates of the webinars are finalized, they'll be shared and advertised. And then the Outreach and Training Unit will also provide forwardable email messages to PEB benefit administrators, who then in turn send them out to all of their employees. These messages include important information such as open enrollment timelines, changes for plan year 2025, and information about how to make changes during open enrollment. And then benefit administrators will communicate with Outreach and Training through either the HCA support portal or through our toll-free line. Next slide. Last year, we hosted 15 benefits fairs across the state. We received a lot of member feedback, which we used when we started planning for this year. Locations for this year's benefits fairs were selected based on member enrollment information. I've included the dates and times and locations on the next slide, which I'll go over shortly. Based on feedback we received, we are working with our communications team to have the printed materials available at the first benefits fair, as well as on our website in early October. We're planning to increase our staffing at the fairs to help support the needs of our members. We started planning earlier this year for more of our program staff to attend to address member questions. And then for the fairs this year, we have the fair scheduled for any member to come during any time of the day, rather than dedicated time based on member type. This year, we'll again offer virtual benefits fairs. And just as a reminder, virtual benefits fairs is an online website created with the same goal in mind as an in-person fair. And some of the features, members can access information 24/7 from their home. They can access it via computer, tablet, or smartphone. And some carriers provide direct interactive webinars, pre-recorded webinars, and conferences to share plan-specific information. Next slide, please. So as I mentioned previously, on this slide, you'll see the dates, times, and cities for the 15 fairs hosted by HCA. One thing I'll also note, with the change in open enrollment dates, the fairs do start sooner. So we start those when open enrollment starts. Give you just a second to look at that, and then go ahead and go to the next slide, please. In addition to the 15 fairs that HCA hosts, we'll also be attending the 4 fairs hosted by University of Washington. Those are scheduled October 21st through October 24th. On the 21st, the fair will be at Harborview Medical Center. On the 22nd, it will be at UW Medical Center Northwest. The 23rd will be at the Warren G. Magnuson Health Sciences Center, and the 24th will be at the Husky Union Building. The specific details about these fairs and the fairs on our hosted fairs on the previous slide will be posted on our website as well as in the October newsletter. So next slide, please. This year we have a similar communication strategy as we did last year. We'll have social media posts, forwardable email messages shared with employers, retiree association presentations, the retiree customized letter, and an alert banner in Benefits 24/7. We'll also include a website alert on the front of hca.wa.gov so that members can easily go to the open enrollment web pages to view important information. And then we'll be using the October newsletter to call out information members need to be aware of when considering plans for 2025. The front page will describe the steps to take to make enrollment changes and include prominent alerts about changes for plan year 2025. And then also, Ellen also mentioned in her presentation some specific mailings that will also be going out in that September-October timeline. So next slide, please. In order to prepare the Benefits 24/7 system for open enrollment, our Benefits 24/7 team will complete performance testing to ensure that the system operates as expected with a large volume of members during open enrollment. They're working on the Vision and UMP Classic Medicare with Part D development. The core development has been completed and the team has now begun the extensive system testing including validating with carriers and the data transmitted to them. There's interface testing to test the interface between Benefits 24/7 and our Pay One system. And then carrier file testing to ensure that the files go to the carrier with for new values. And then we have regular language updates such as plan availability by county, rates, etc.
And just to put a finer point on the interface testing is something that we're paying particular attention to. I know that the word syncing is a word that has been said many times this board season, as we've brought updates about some of the challenges of connecting the enrollment that is made in Benefits 24/7 and syncing that into the system that produces the carrier files and the accounting. So interface testing is a really critical piece. Just wanted to make sure that people know that that interface testing is code word for syncing.
Yep. Thank you. All right, next slide, please. There are some ways that members can prepare themselves for open enrollment. So for members who are considering changing their plan, the best way to prepare is to make sure that they can log into their online Benefits 24/7 account prior to open enrollment and make sure that their home address is correct. Consider signing up for email communications. They can prepare a list of important questions they may have for plans about benefits, prescription costs, deductibles. Members should make a list of their prescriptions so that they can work with plans to understand how they would transfer prescriptions as well as what those prescription costs might be. And members should review changes by reviewing information in our mailed materials as well as on our open enrollment website. Next slide, please. And then once members have reviewed changes for this year, they should take the action to change their plan, whether that be a form or online through Benefits 24/7. Add or drop dependents. They can attest to any surcharges, review their life coverage, and designate beneficiaries. And then next slide, please. And then for employees, they should elect flexible spending account or limited purpose FSA dependent care assistance program. Complete their smart health incentive, review life and long-term disability coverage. There will be a lot of helpful information and tools on our open enrollment web pages to help members make the changes based on their decisions made. So they'll have a lot of things to review to make sure that they're successful this open enrollment. So that is the end of my presentation. Are there any questions?
Yes, do you still key off Secure Access Washington? Do we still have to get into that system first? God help me.
Yes. So to access benefits, it's not the answer I want to give, but to access benefits 24/7, you do have to go through SAW.
So can we get help from you guys getting into that?
Yeah, we definitely are offering help now to folks that call in and need help logging into the system. So our customer service team has been providing that support. And that's really why we're recommending people try logging in prior to open enrollment so that once open enrollment gets here, they've already gone through that, getting through their SAW account and getting into the system. So folks should, I really encourage people to try getting into the system now.
And just FYI, they are, I believe they're in a procurement for SAW 2.0, looking for something a little more user-friendly and better. I don't know when, it's not coming before this open enrollment for sure, but it is on the to-do list for WATEC.
And by they, just to clarify, you mean WATEC, which is another central agency that works on IT security for the state and everyone uses. So just to be clear, it's not a procurement that this agency is doing. We are but one of many players of the use of SAW.
So as a retiree, and I can say this of other retirees, it isn't clear to us that you guys can help us with the SAW system. If there's some way that you could clarify, that call us, we'll help you get through SAW to get into. Because I was a tester, I couldn't even get out of SAW. I couldn't even operate SAW to even get to test benefits 24/7.
I just want you to know that I can beat you because I had at one point 8 different SAW accounts.
You win. Other questions for Alyssa? All right. Alyssa, thank you so much. Appreciate it.
Thank you.
8 accounts. Did they all work? No. Okay, perfect.
There you go. I think having eight made it challenging to have any of them work, if I remember right. I believe I know who helped you with that.
Sure do. All right, next up, we have the consolidation report update. Mr. Kate Walker, Policy Rules and Compliance Section Manager in the IRF Division, is going to present us an update on the work being done for a legislatively mandated report regarding PEB and SEB program consolidation. His materials are behind tab number 9. Do we want to do questions along the way? Because yesterday there was a lot of questions, and so I just want to make sure we manage this.
Yeah, I'll just say as we go through this presentation, there are 4 discrete topics, and we'll make sure Kate goes through the materials for a topic and then pause to talk about that topic. For example, board structure, and then the materials about eligibility, and then we can have an eligibility conversation. So each section by section. So we'll have Kate go through the materials on that section and then open up for dialogue on that topic.
Fair enough. Kate, you got your Joe in?
Let's do it.
All right.
Oh, shoot, pen down. And apologize if I'm a little distracted. I've got the neighbor outside. He's using a blowtorch to do some weeding, and that's causing me a little bit of angst because it sounds like a hot air balloon going up outside my window. But
those are totally safe. Don't worry about it. They're not a fire hazard.
I'm not worried of them lighting my house on fire at all at this point. But it is. So if I'm a little jumpy at times, it's because that keeps kind of startling me. But anyways, Chair McDermott, members of the board, I'm happy to be here with you this morning. Again, Cade Walker. My pronouns are he, him, and I'm wearing a blue check shirt with a wooden bow tie. I've got long brown hair and a cis white male. So I'm here to talk about, as mentioned, the consolidation report, which was required of us in the budget from this last legislative session. So we'll start with the next slide, please, to go over a little bit of what we're doing. And this report from the legislature is asking us to write about the potential for consolidation of the PEB and SEB programs. This is not a merging of one program into the other necessarily. It's really taking the 2 existing programs, the PEB program and the SEB program, and working to help conceptualize what a consolidated program would look like and what some of the logistical options might be related to 4 particular areas, which are discussed on the next slide. And so, so actually, I should be following my own slides. This is going to be the brief history of consolidation reports that have been done. There's been a lot of them. There's been at least 10 of them since the late 80s. I find it a little fun right now. I came to the Healthcare Authority 10 years ago, and my first responsibility coming to the Healthcare Authority was writing the report that was listed for 2012 and Gross Substitute Bill 5940, which that report was published in 2014. So this is a topic that I'm very familiar with consolidation, but for the most part, the consolidation reports that have been done historically have really focused on the consolidation of the K-12 purchasing. As you might remember, historically, while PEB and its SIBE and other iterations of PEB from the decades past, we won't go into all the different acronyms of it, the K-12 world had largely been fragmented. In 93, they attempted to consolidate, or they passed legislation to begin that process of consolidating the K-12 benefit purchasing. But then the subsequent year, that effort was rolled back. But at that time, they did say, well, all of our K-12 retirees, we're gonna leave in the PEB program, which is what created the retiree subsidy and why all of the K-12 retirees are in the PEB retiree program. That's a legacy from that 93 effort. But there's been a lot of efforts since then, or reports and looking at consolidation of K-12. In 2014, the 2012 report that was published in 2014, that report did take into consideration what consolidation of the K-12 purchasing would look like in a couple of different scenarios. Some of those scenarios did include a consolidation in with the PEB program itself. And other options included creation of a SEB program that would be parallel in mirroring the structured PEB, which is what the legislature ultimately went with when they created the SEB program in 2017, that was then implemented effective 2020. So you can see a long history of reports, but the last one from 2020 is really the only report that really dived into some of the details of what consolidation of the PEB and SEB program are. And it did include a lot of information kind of about some of the financial benefits that may exist because of consolidation. So it's a report we're leaning on quite heavily. So that brings us, I think, to where we're at today. So next slide, please. Legislature in their budget asked us to report on 4 areas of consolidation of the PEB and SEB programs. First, they wanted to have a single governing board structure and list out some of the options that are available for that. Second, they wanted us to consolidate the risk pools for the active and non-Medicare retirees. Third, they wanted us to make sure that we're maintaining the current eligibility for all eligibilities in both the PEB and SEB programs. And last, that there would be a single aligned portfolio of benefits. Now, this report is due December 1st, so it's a fairly short runway given the review process that we have to go through, which means our completed draft will be ready for review come September for the review process that goes through with the governor's office and OFM. But it is important for us to know, and I think this is important for those who are listening and those in not only on the board, but also stakeholders and members who are just interested about what this report is going to be doing and what you can expect from this report is that there's not going to be recommendations from us. We're not necessarily taking a policy position on whether to consolidate or not to consolidate. This is the legislature asking us provide the best information as the experts on these 2 programs of what a consolidated program would look like. We don't necessarily need to provide recommendations, but that's what we're offering as far as our expertise on what these 4 areas would look like or what we would need to do both statutorily and regulatorily and administratively to make sure we're preserving or achieving the 4 areas of consolidation that the legislative report is asking us to do. Lastly on that, we will be providing as part of our report the statutory language that would be able to be implement at least the changes that they have asked us to consider for consolidation, although there are certainly some policy levers within those statutory changes that would be dependent on what the legislature would want to choose when there's some different options like on the board size or maybe other requirements as it pertains to what benefits to be offered in certain things. So moving on to the next slide, the requirements also had a couple of additional considerations that the legislation wanted us to take into consideration. I was writing the report. First is that we have a deliberate engagement with the impacted participants, those who are impacted by what consolidation would happen. That means all the active employees in the PEB and SEB program, retirees as well, because there would be an impact to that. There'd be potential impacts to them. We're looking at the administrators, the benefits administrators, and the PERS pay staff and agencies, and other interested stakeholders, as well as interested parties that are not necessarily directly part of the PEB and SEB program. Then they also wanted us to again ensure that the eligibility that exists for the PEB and SEB programs would not be messed with. It would be maintained. Obviously, putting it in both parts of not only the requirement but additional considerations really highlights the importance that the legislature has on making sure that eligibility remains the same in a consolidated program. They also want to make sure that we're taking equity into consideration. And also looking at our previous reports that we have done and bringing forward any of the information from there that's pertinent for consolidation consideration, which is a nice little rhyme there. Next slide, please. So let's get into some of the details here. So talking about a single governing board structure. Next slide. Oh, go ahead.
I'm sorry, Kate. I just want to ask a couple of questions about history.
Sure.
It's my understanding that, first of all, the legislature was under the gun to create what we now know as the McCleary fix because the state Supreme Court had ruled that they were not fulfilling their constitutional duty to make education their paramount response. I think it is in the actual Constitution that public education is the paramount duty of the state, and they weren't fulfilling that. And so the legislature actually drug its feet to the point where the state Supreme Court was fining them on a daily basis until they came up with a fix. So when they came up with the fix, literally it was boiling down to the end of the legislative session. And they took what each school district at that point was responsible for its own salary and benefits. The amount, I'm sorry, not the salary, the benefit piece. When I worked for North Thurston, we had certain options where we could get our health insurance through. Whereas if you were in, say, the North Shore School District, you had a different set of options for your healthcare providers. So that was all the way it worked, but there was a statewide salary schedule. So what the legislature did is they basically dumped the state salary schedule and left it up to each district to negotiate how they wanted to disperse this money that was supposed to be allocated for salaries. But at the same time, they said, and this is where the SEB comes in, at the last minute, this was my understanding from our conversations here at this board, they threw back in the SEB. It had not been part of that conversation until literally the last couple of hours before they adjourned that session. Is that correct?
Kate, I'll take this one a little bit.
Okay.
I think it's fair to say that the creation of the SEB program was not a necessary component to comply with the McCleary decision. But as the legislature was, I think Kate's highlighted, it's been a long-standing conversation about whether there is pooled purchasing power for K-12 employees at a state system, and it was talked about for roughly 30 years. And so, yes, the legislature, it's called the Omnibus McCleary Bill 2242. It didn't have to include anything about benefits. That wasn't really central to the McCleary decision at all, but the legislature took the opportunity to address that longstanding topic that they've been debating for decades and did it at that same time. And, you know, earlier in that same session, there had been a standalone bill around that then Senator Hobbs there were hearings on it. I remember testifying on those hearings at that time. So, you know, like many pieces of legislation, you see bills combined and ideas combined and put together all at, at various times of the process, including the last day. And so I think, there were components that people in the legislature were very aware of this topic. But yes, they did take the opportunity to put that in that to create the SEB program as part of the McCleary bill, even though it was not a prerequisite for complying with McCleary. Okay.
Good, thank you.
Yeah, and I know another aspect of it was that, the McCleary was saying that funding was a paramount duty and making sure there was adequate money going into the school systems. I know there had been conversation that we had put forward saying that, funding teachers and educators and paraeducators, everyone, and having those benefits be more streamlined. I know that because of the passing of SEB, it did require the legislature to put a significant larger investment into the benefits for the K-12 educators, which was part of their efforts towards moving towards compliance with the McCleary decision, the McCleary mandate to fully fund education. So a lot of interesting history, and it's been great to see over the last 10 years what progress has been made. Considering I joined the state 10 years ago for the specific purpose of writing that initial report back in 2014. So it's been a fun 10 years to kind of almost come full circle in a way to see where things may end up in the next few years. So with that, I just want to go over the current board structure real quickly. This shouldn't be news to either this board or the board presentation to the SEB board, which we gave this presentation to yesterday. But just as a reminder, the current PEB board construction has 7 voting members, with the Healthcare Authority Director being the chair. This is the chair for both boards, or the Healthcare Director's designee, as in the case for Lou. There's an equal number of benefits management and cost containment, or the health benefits policy administrators, to the members who are representative of the employees or subscribers in the different boards. For this board, we do have a non-voting benefits management and cost containment member, which then leaves the 7 remaining board members with 1 board member representing state employees, 1 representing state retirees, and 1 board member representing school district retirees. So next slide, please. Just real briefly, the statutory language that develops the board composition are found both within RCWs 4105, 055, and 740 for the PEB and SEB boards, respectively. And just a couple of quick insights, as I had mentioned, about the equal representation between those board members who are health policy and cost containment type representatives, and the representatives of the covered populations, whether those are the active employees in the PEB, the SEB side, or the retired and other types of covered individuals. Next slide, please. So in thinking about looking at what a single governing board would be, they came up with essentially three frameworks of which a new board could be constructed to oversee the consolidated program of taking both the PEB and SEB and consolidating them. So we have first the proportional. And then we have an equal, and then we have combined. It's just kind of the phrase, we know words kind of matter. So this was an easy way for us to kind of use one word to describe the kind of options that we came up with regarding what a consolidated board could be. And also important, we want to show the medical plan enrollment to show, as we look at the some of the most important aspects of what the board does every year, as you just did earlier in the meeting, which is approve rates for the medical plans. There's not a need to approve the rates for the dental or vision because those are covered at 100% by the employer. But the medical plan enrollments, I think, are pretty important for recognizing the representation which are on the boards, especially for some of our options that we put forward. So you can see here between the populations, the active employee populations in the PEB and SEB program, and then the retirees, there's about a 2 to 1 ratio in the number of subscribers or total covered lives between those three kind of categories of individuals that are covered by the medical plans offered by both the PEB and SEB programs. So with that, let's go to the next slide and we'll show you the three concepts that we have come up with for potential board designs. And again, remembering that we're not making any recommendations, we're merely providing options for the legislature to choose. If they decide they want to go and pursue legislation to consolidate the programs, here's some options they could choose to plug into the legislation they propose. So from the proportional representation, it would be a board consisting of 11 members. All of these would have the healthcare authority's director or designee as the chair, as it is currently. Then we would have the equal number of what we would refer to as benefits policy and cost containment board members, equaling the same number of board members that represent the populations. So you see here under the proportional representation, we would maintain that 2 to 1 ratio that looks similar to, or that comes from the medical enrollment lives, as shown in the last slide. And so we'd have 2 representatives for state employees, 2 representatives for school employees, and 1 representative for retirees. The equal representation option would see the number of board members for retirees double. So we would have two representatives for all 3 of the categories of populations, the school employees, the public employees, and the retirees. And the last option is essentially taking the existing board members with consideration that there's a non-voting member on the PEB board and that the chair is the same, would be the same from both the PEB and SEB program. We end up with the combined representation. And here I listed with the current structure of the board and what's delineated in statute for what those particular board members represent a little more granularly than on the PEB side. On the SEB side, it does delineate that there's 2 representatives for classified and 2 representatives for certificated employees, and that there's a delineation for a state and a K-12 retiree representative as well. So just those are the 3 options that we put forward. Of course, there's numerous different types of board structures that could be conceived of, and not to mention there could be other non-voting members that might be considered. But we felt this kind of represented a good mix of showing you can have ones that are representative, commensurate to the population sizes, one that's just as Dave likes to call it, the Senate model, where every state gets 2 representatives. And here we have 2 representatives on the equal representation side, and then the combined, where we put them all together and you have an entire congressional body. So with that, I want to pause for a moment and see if there's any questions or if Dave had anything he'd like to add from this.
Dave, can you describe a little bit? I know you and the team looked at the 200 and some boards that the governor has already over. To give a little context of overall size of boards and why we kind of kept these ideas in the 11 to 15 range, and then I'll definitely open it for questions.
Yeah. So thanks, Dave. I was just trying to expedite. I went a little long yesterday, so I'm working to try and trim up the timing on this one a little bit more today. So in looking at the different board size and compositions of the 260 plus boards that are currently under the governor's office's jurisdiction, had my staff run through and say, all right, what's the number of total members on those different boards? And from the 260 or so boards, there's a pretty interesting bell curve where you have boards as small as 1, Very few of them have as small as one. And I think then they're on the far end, there's some boards that have 40 or more board members. But the vast majority of the boards you'd see on a bell chart, you'd see them really starting at about 5 to 7 board members. It starts to peak up around 5, 7, and 9, and then starts to taper down around 9 to 11. It starts to taper slowly down till you get way out there on the other end of the curve at about 43. So while the median seems to be about 7 to 9 board members, given the scope of population that's served by this board, we felt that it wasn't unrealistic to have 11, 13, or 15 board member board, even though that the 15 would certainly be getting closer to the far end of where the boards are. It still seemed to make some sense to put it out there given the population that's served by that board.
Thanks, Kate. And so, Elliot, I see you have the first question.
Yeah, just an interpretation question. What is the, like, for example, you have benefit policy and cost containment in the very first column, and then you have X5. What does that?
5 members.
That means there's going to be 5 of those positions. So you can see the total number of members being 11, and if you count the listed, you have the HCA director, the 5 benefits policy and cost containment, and then the 5 representatives of the populations, the categories of population. So the 2 state employees, 2 school employees, and 1 for retiree. So you have those 5 board members who are representing the populations, and you'd have the 5 commiserate board members that represent the benefits policy and cost containment. And that's where the times 6 and times 7 kind of follows that same pattern for the equal representation concept and then the combined representation concept.
We're really interested in any of your reactions or thoughts, because, this is, we're essentially yesterday and today with the boards kicking off stakeholdering and asking for insights. And, we're writing the report as we're writing this presentation. And so there's much more work to come. And so feedback, insights, perspective, all of that totally germane at this point. Harry?
Yeah, just not sure. Well, one comment, I guess, because it's sort of personal, I guess, is I benefits policy and cost containment. I looked at the RCWs who said in the PEB, as I view the job description, if you will, of the position itself and some others are in, it's quite a bit different than what it would be on the SEB side, which leans towards policy and administration. Over the years, I personally think that the benefit position should bring is in cost containment, benefits management, and not necessarily the policy. And so I would urge that things shift around so that that's the emphasis, not policy, because I think that's really what that board positions are intended to bring to it as I look at the history. And then I guess the other comment, I don't really have a sense of which one might be the better of the best, if you will, or recommended, but I do think that, and I would lean towards Kurt and others about, well, do there need to be 2 state employee reps? I think one does a pretty darn good job. I don't know that there need to be 2 school employee. Because right now they only have, I don't know what they have now. But I may be wrong there. I don't know why we would want to increase the number of positions by adding duplication. Hold that. Sure.
Yeah, here, I'll just give the interesting context of this is that the SEB board has 4 employee representatives. Half of the board for SEB is 4 employee representatives. So if you that's why it's interesting to look at the combined representation column. If you just literally put everybody in a room together, you'd say we have 4 school employees, 1 state employee, and 2 retirees, 1 from state and 1 from K-12. And some people might be really happy with that representation and other people might not be as excited about that representation. And that's really what got us into thinking about, the far left column is the House of Representatives proportional representation model. The equal representation is the US Senate, equal representation for all populations model. And then the combined is, well, let's put everybody in a room. It really is, from the different populations will have different perspectives based on the current status quo of their representation versus what a future could look like. And so, yes, from today's perspective, we have 1 Kurt in this room. Yesterday, we had 4 CURTs for school employees. And so it's just kind of everybody's at a different starting point. And that's why I think people are so interested in this particular part of a consolidation is I think many people's initial reaction to what would a governing board look like? Would it even have representatives of the covered lives? And we've always been under the assumption that if there were a single consolidated board, the answer to that would be yes, there would be representatives of the very people that are being served. And so one of the things we were hoping to convey as we level set with stakeholders about how the agency is writing this report is, yes, the assumption is that there are representatives, that the question is, well, then how do you divvy up that representation? But not if, it's a how question. So that's the hard part here is, because you're right, from the perspective that you've had on the board for the last 8 or 10 years, if I remember your service right, like you've experienced Greg and Kurt, one person for state employees. On the SEP side, in the last 5 years, there's always been 4 Kurts, for lack of a better description. But I'm going to turn over to Kurt because he raised his hand and I kept saying his name, and then we'll go to Tom.
Thanks, Dave. Yeah, I mean, I think based on the models that you've provided here, that in the interest of equal representation, we would be, as representing state employees, for the very fact that you pointed out, in a combined representation, we would be far outweighed by 4 of me on the other side versus 1 of me on the state employee side. So I guess, our interest in representing state employees, we prefer the proportional or equal representation models for that reason.
So yeah, I was thinking about the combined representation model and the 4 school employees, but I think it's important that you differentiate a little bit because it's not just, it's like some people might think, well, that just means 4 teachers or active teachers, but it doesn't. It represents custodians, it represents office professionals, it represents active teachers, and I believe it represents administrators as well.
Yes, superintendents, food service workers, bus drivers, everyone.
Correct. So we actually distinguished out between those different bargaining groups and gave them representation. So it wasn't, I understand what Kurt was saying when I look at those 2 models, but it is important to note the difference in the 4 groups of school employees.
And Tom, I think to that point, in the first 2 models that we proposed, we didn't put the same sort of context for splitting up the state employees and the school employees, like in the current model and the combined model. You can see under school employees, those representatives are certificated. 2 represent certificated, 2 represent classified, to distinguish kind of the large split in the K-12 world of employee types. It really comes down between certificated and classified employees. Certificated being those that are required to have a certificate, like teachers. Some administrators, librarians, et cetera, are supposed to have particular certifications. And then classified being the staff that are administrative, or the groundskeepers, or para-educators, are the lunchroom workers, bus drivers, et cetera, like that don't have a certification requirement, that fall into the classified categorization. On the models that we created, we didn't put that delineation. It would be assumed, I think, and we wouldn't assume that would be necessarily the case if the legislature didn't want it, but we would have really assumed that for the 2 school employees, representatives on either the proportional equal board, that one of them would represent certificated interests and the other would represent classified interests. And I can see a similar thing for the state side as well. If you consider the higher the agencies that are represented by Kurt, and but not only the agencies, but then you have higher ed. So maybe that is split between the state agencies, state employee representative, and higher ed state employee. But I could see there being another sort of differentiation where there are kind of some distinct populations that might have, some different interests that want to be represented on that board, and we could see how what the legislature might do with that. But right now, with it only being one state employee representative that's responsible for covering the entirety of the 140,000 employees that are the active employees on the PEB side of things, relative to 4 that represent the 120 some odd thousand employees on the K-12 side.
Kyla?
I don't know if this recommendation is feasible or not, or if it makes sense, but I wonder, with all the conversations around health equity, and I think there are many of us who are trying to bring a lens to it, but just wondering if it's possible to call out a voting member with a health equity lens.
I think that's a really fascinating idea, and one that is something that has as a potential for putting in. One of the options I had contemplated, and Dave might kick me for us a little bit, but it could even be a non-voting member. There are non-voting members, and there could be different interests that are represented and have that perspective that's able to be shared with the board as a non-voting member. That could be an option. I think it's certainly feasible, and there's a lot of possibilities to have non-voting or even more voting members if there were to have a health equity voting member. I know Quinn Wynn, our health equity director, would probably be a big fan of that. But I very much appreciate the idea, Michaela. I don't know if Dave wants to kick me on that one later, but I do like that idea.
I think there's a lot of different perspectives on it. It's just there's a point where you just got to balance the number of people in the room. I think it'd be a bad idea to have a 43 member benefits board, but there's all sorts of gradations here, and that's why these aren't the only three models, but these are three fundamental ways to think about it. And so, this type of feedback, these are the types of things we're interested in at this point as we're drafting things. So, thank you, Michaela and Harry.
Yeah, one other thing, I had a little bit of better chance to digest it, and actually hearing Kurt and some others regarding representation. I kind of think I would like to be somewhere in the middle here with equal representation. Only I would urge that the benefits policy cost containment only doesn't be put forward. If you can get, I'm struggling with the way to say this, if you can get staff it with 4 people that actually really have that experience to provide to this, I think it would be more impactful myself, and it would also bring it in line more with not being dominated by 6 of those positions versus only 2 for state employees and 2 for school. I just think it's, if we want to talk about equal representation, then I think 6 is a little bit more equal than 2. Yes, I think 4 would be workable, but whatever you guys think, it's fine.
Well, I think, one of the interesting things about this is the report will go in, the legislature will take their report, they'll do their thing, but then there will be the process. So if they want to address this policy issue during this time, there's going to be a lot of turnover in the legislature. We got a new governor coming in. We got a lot of stuff going on. It will be interesting to see how the politics plays out, because people definitely, it's their opportunity. Before the law is codified, it's their opportunity to go in and say, this is what I think we should do. And, how much they engage HCA and have discussions with us, it's kind of up in the air. Sometimes we're like, oh, we thought we would be more part of that conversation. Other times we're like, why are you asking us that? So it will be an interesting legislative season if this gets airtime.
Just to reinforce that, a changing or creation of a single board would require a bill in the legislature. A consolidation of risk pools would require amending existing statutes. A collapsing or combining or putting together of the eligibility framework requires a bill. These are all things that can't be done via a budget provision. They all are topics that have some form of existing statutes that have been enacted by the legislature, signed by the governor, and would need amending. So, that's why these are discussion topics about to inform any legislative process, but any of these would require a bill. Now, sometimes bills are very quick, as Tom pointed out, from 2017, and other times they have a very long journey or a multi-biennial journey, but it does require an active legislature on all of these.
So this report could incorporate, for example, what Michaela suggested, and you can say, well, we could put that in. And then also what Harry suggested, that could also be a consideration that's an option that you present as well. All of those things are options that could go into a report that doesn't necessarily say, well, these are our three choices, but rather these are the options that we have that you, meaning the legislature, can choose to operate on once they get to that new governor and new.
And the legislature is free to do with our insight whatever it wants. I mean, going back to the history of consolidation, prior to SEB, there were recommendations asked for from this agency, and the recommendation was consistently consolidate into a single program. And then the legislature created two programs. So, they were very well on the topic, and we discussed what two programs would look like. But the recommendation we were asked for it always was to create a single program. But the legislature and the governor can sign whatever bill they want.
And for those folks who wonder how these reports, the mechanics of how it happens is we get assigned the report through the legislative process. We assign individuals internally who are responsible to write the report. Then the report is peer reviewed inside of the agency. Then the report is reviewed by OFM prior to hitting the button. And then after the back and forth that occurs with OFM, then the report is again reviewed internally and then finalized and sent out. So there's a lot of steps for a lot of eyes to get on it to be like, oh, maybe we should include this.
Done this already, or
OFM has not done this. Cade is currently working on the report. Cade, when do you estimate it'll go over to OFM for review?
It'll go to OFM, I believe, in October. And we have our internal review process. We'll start, I have to have a completed draft ready for our internal review process with our legislative affairs and analysis team at mid-September. So I have a draft that's getting close to having a time to start getting internally reviewed by Dave and our leadership. But that's kind of a backwards on the timeline. So the end, when it starts going over to OFM for the governor's review, is going to be, I think, late October, first part of November, to hopefully hit our, we're on target right now to hit December 1st for our deadline to have it to the legislature.
Appreciate that.
Sharon.
Great. Thank you, everyone. And thank you, Kay, for that presentation. It was very helpful. This is just a bit of a wrinkle that I'm throwing in this. I get the consideration of representation and the number of people within a particular body. The one thing that I thought about too is representation according to priorities for each of the different bodies. And so what I mean by that is this: what is a historical priority? I'm just now serving on the PEB board, and certainly I'm not familiar with the SEB board, but what is a historical priority, for instance, for the SEB board, and assuring that you have representation or a number of people, a sufficient number of people to address that priority. And an example of that priority could be, say, disability status, for instance, within academia, or possibly K through 12 concerns within that division. And so just again, throwing a bit of a wrinkle, number of people, yes, but certainly historical priorities that are meaningful for the various boards may be a relevant consideration to assure that that's being addressed, especially since you're merging two domains. That could be very important to assure that nothing falls in the cracks, between the cracks, and that we're addressing all the primary issues that each body require to be addressed. Thanks.
Thank you very much. I very much appreciate the comments, and I think you're absolutely right. I think there's an opportunity for us to include language that can help the legislature in their ultimate decisions that they need to make to keep that perspective, that historical perspective on priorities in their considerations for designing, what they want that board to ultimately, what they hope for that board to look like.
I'm going to use this as the opportunity to highlight that we can definitely, you can reach out to me and Cade with additional insights on these topics as we go along. I do think it would be good for us to tee up the second. We've gone through one of four, and we're already over time, but I should have time budgeted this a little bit better. But I do think it would be a good idea to have Cade start to talk about the risk pool piece so that we can move to topic 2. But you can certainly reach out to Cade and I after the meeting to share more thoughts that you have as well for us to take into account. So go ahead, Cade.
Yeah. Oh, absolutely. I will gladly hop on a call and chat policy with anyone who's so interested during work or even after work. This is something, like I said, I've been involved in 10 years working on this work, and I thoroughly enjoy it. It's what has kept me really engaged at the agency. So let's talk about the risk pools real quickly. This section I think we'll go through fairly quickly. It's probably not nearly as exciting as board composition, but important nonetheless for the legislature to call it out. So let's go to the next slide and we'll look at what the current risk pools are. Currently, there are 3 risk pools between the PEB and SEB programs. There's the PEB program non-Medicare risk pool. There's the PEB program Medicare risk pool. And then there's the SEB program risk pool. And each of those have particular populations that are found within those risk pools. And again, those risk pools are the grouping of populations that are used for determining the relative risk for determining the costs of and premiums for getting the different health benefits or LTT life and all those other groups that we purchase for. Those are kind of the grouped buckets of, if you will, of the population. So for the non-Medicare, the PEB program non-Medicare risk pool, that covers all of the active state and other employees, other being those employees from the political subdivisions, COBRA, leave without pay, employees or retirees and their dependents who are not Medicare eligible. That also includes the state non-Medicare retirees and the non-Medicare school retirees. The Medicare risk pool, obviously, it's for the state and other employees who are Medicare eligible and the Medicare eligible school employees. Then on the SEB risk pool, it just represents the school employees. So the legislature in their request, all right, you're going to consolidate the 2 risk pools for the 2 non-Medicare risk pools. So let's just go to slide 14, or just hop over the next slide because it doesn't really, and not too much information there to share aside from where the statutes are found, and I won't get bogged down in statutes for this. So we come up with we result in consolidating the 2 active non-Medicare risk pools, and we would have the Medicare risk pool which would remain the same. So comparing slide 12 to 14, you can see we took the populations that were represented in the 2 non-Medicare risk pools and put them into a single risk pool. So you'd have a single non-Medicare risk pool that would be comprised of state and other employees, the school employees, the state and other non-Medicare retirees, and the K-12 non-Medicare retirees. And then we would have the remaining Medicare risk pool, which would still have the state and other employees who are eligible for Medicare and the Medicare eligible school retirees. So probably not, I mean, if there's any questions on that, I'd be happy to take them, but I think it's a little bit more straightforward. It's, again, administrative of how we would combine the populations. And I think that does lead into some aspects of how costs would be impacted, because now we're taking the relative risk of the entirety of the school population, school employees, and then we're merging that with the entirety of the population of state employees and the non-Medicare retirees and other populations into one grand pool. And of course, there's going to be a little bit of impacts that result because of the combined risk, the relative risk of those populations. And that's something we'll address a little bit further in the presentation. But for now, I just wanted to pause and see if there's any questions about consolidation of the risk pools, the consolidation of the non-Medicare risk pool.
Just to reinforce, the effects of this, of combining the risk pools, is analysis that is being done, and there'll be description of it. This part that we're describing here right now is just making sure people understand what was asked to be done. We don't have extensive fiscal insights on the effects of merging the pools at this point, but that is work that is being done, and there will be descriptions of it in the report. But when the budget provision came out, one of the first questions was which risk pools? And so we just wanted to make sure people knew what the question was, and there's a lot more answers and analysis that needs to come. So don't think that the absence of fiscal information here today means that there won't be that in the ultimate report. That will be coming. But we wanted to make sure people knew the question that was being asked, because there were a lot of questions on what this part of the report actually was looking at.
Yeah, and also to reiterate that a lot of the work that was done in the 2020 consolidation report included that the fiscal analysis of what consolidation would look like, understanding kind of that consolidation model from that 2020 report, which had some different requirements that the legislature asked for that report to contain than this report that we have. This one's looking much more at kind of the administrative and statutory side of things, The report from 2020 did take a look into more of the fiscal impacts and some of the potential administrative savings that might exist in it. And so we're going to be carrying forward a lot of that analysis that was done because it was good policy then. It was good policy work now. They'll be carrying forward into this report and updating it with some of the new experience we have since the last 4 years since that report was published, or really 3 years.
The important piece is there has never been a report where we've actually had data on K-12 employees. This is the first report where we actually have claims data that we had at the state aggregated to be able to analyze. Even in 2020, it was based off of projections of synthesized data from 295 fragments. But this is our actual data that we're able to use. So Tom, you had a question?
So, Kate, just to make sure, that first part of our discussion was really about if we have to combine the SEB and the PEB, there's different options. And we looked at 3 of them, but there are other considerations that could end up being part of that. This part is actually not necessarily just combining them, but rather creating 2 separate boards that would look different than the current 2 separate boards. Am I understanding this correctly?
No, let me clarify a little bit. So the requirements of this report that were listed in the budget this is where the requirements for this report came from, said, all right, we're looking at combining the programs. And now I do want to be clear that they didn't say that we're going to take SEB and merge it into PEB. It really is, they've said we're going to consolidate the 2 programs into a consolidated program. And they gave us 4 areas that they wanted us to provide information on, because we are much closer to that work. We understand the statutes. We understand kind of administratively, conceptually. This has been our in our arena for quite some time. So they asked us to provide information on 4 particular parts of what a consolidated program would be. So the idea under all 4 of these areas of interest that the legislature asked us to report on is an assumption that there's going to be a consolidation of the programs. So they have the 4 aspects they want to look at, which is 1, what a consolidated board could look like. 2, they had the specific requirements for consolidating the risk pool for the active the non-Medicare populations, which, you know, if I can get the slide to go back 2 slides, please. You see, this is the current risk pools. These aren't the board. Now, certainly there's the SEB board has one risk pool under its kind of a jurisdiction of what it has responsibilities for. And the PEB board has 2 risk pools that it has responsibility for. The legislature said, all right, if you're going to take the non-Medicare risk pools, and they specifically called out from the statutes, the 2 non-Medicare risk pools, the one for PEB and one for SEB, and combine those into a single risk pool. And then we would leave the Medicare risk pool alone. So this is the current, we're going from 3 risk pools under either the PEB or SEB program. And then if we hop forward 2 slides, so this would be the result of the consolidation of the 2 non-Medicare risk pools. It would still be under the jurisdiction of the consolidated board, whatever that name of that board would be. We are not proposing any names. We're not PRing what the name of a consolidated board would be. Probably not going to be PEB, because we want to, I think the respective idea would be not to just assume that it's SEB being merged into the PEB program, that we really are creating a new consolidated program, but that has some requirements of maintaining a lot of certain characteristics of the existing boards. But this one being the risk pools, we're consolidating that non-Medicare risk pool from the PEB and SEB sides into one non-Medicare risk pool, and then leaving the Medicare risk pool, both of which would be under the jurisdiction of the new consolidated board, whatever design it is that they would choose, they being the legislature.
So a single board that would have 2 risk pools under it, sort of like today, the PEB board has 2 risk pools under it. Right. Not really, they're kind of completely separate questions, Tom.
Yeah.
All right.
When I look at these 2 slides, it kind of looks like there might be 2 separate boards.
Yeah, that's good to know that is a potential interpretation of the slide. That is not what it's intended. It's intended to be, there would be 2 risk pools within a single program that has a single board. Question 1 was, what does the single board look like? Question 2 is, what does the risk pool arrangement look like? In the legislature foreshadowing, they would expect 2 pools. And so HCA tell us the effects of that. So the first one, there's options to describe because there are policy levers the board could make, that the legislature could make. Here it's tell us the effects of effectively of merging two of the existing risk pools together.
Just hypothetically, if you were to include, or could you include in your report, say, another option? And that is if you wanted to maintain two boards instead of consolidating one board, could you recommend a non-Medicare risk pool as one board and a Medicare risk pool as a separate board? If the legislature deems that it wants to keep separate boards, it would seem logical, if that is their intent or their desire, that you have non-Medicare active employees in one risk pool because they have interests that do not necessarily dovetail with Medicare retirees for both public employees and school employees. So could that be an option that is mentioned in the report that you bring forth to the legislature?
I would say the answer to that is no, Tom. I have three different pieces to think about. We're not making any recommendations. So I just want to be clear that there are recommendations here. The second is on the risk pooling piece, the language was very specific. It's like, tell us the effects of merging pool 1 and pool 2, citing the specific statutes. It did not say like the part for the board with like, tell us options for a single board. It was like, tell us the effect of merging A and B. And so that doesn't leave open the window for describing other options. It's described the effect of consolidating those two specific risk pools. And then third, I'll go back to the very beginning of the board meeting. There is a relationship between moving from employee non-Medicare status to Medicare. I mean, I wouldn't have had my opening statements about the relationship of substitute teachers and eligibility and how that interacts with being on PEB Medicare benefits. So, if we were in a hypothetical world where you would potentially talk about two boards, there is a direct interaction. I mean, there's a reason that the PEB program today has two risk pools, and we cover a population that can flow between, as they age, transitions to different insurance options. So, but we aren't tasked with options here. We're tasked with tell us the effect of if we do A plus B.
Okay.
Harry.
I don't know enough about the funding rate and the EMC, but my understanding is they are different between the two groups. If my thinking is correct, then the current pool would make more sense to me than this one would, because you'd still have to probably rely on, although you could still get to it, you could still get to the school employees' experience. You could still get to the state employee experience and pull it out of there. They'd be segregated in some way. I mean, you could see them, but it would still be necessary, I think, to have separate data to look at, because it all goes into the EMC and employee rate. So I guess in a world where everything is the same, then it would make sense to me to have this one.
So Harry, the methodology for the EMC, the methodology is the same now. That wasn't the case a few years ago, but the way rates are calculated, the same methodology is used. Now, obviously, the experience of the two pools is not 100% identical, so the numbers trickle out differently. And so the EMC in PEB and SEB is not the literal same number today. And the funding rate and the budgets is not the literal same funding number in the budgets. But in this future consolidated, that's part of the fiscal analysis that is being done, is to talk about, in the end state, it's envisioned that if there were a single non-Medicare risk pool, there would be a single EMC, a single funding rate, and the premiums that would be authorized by a single board would be the same premiums, whether you're a superintendent, a bus driver, a seasonal worker in the Department of Ecology, a professor at the University of Washington, a nurse at Harborview, or wherever you are in all of the populations.
Yeah, and with that context, this makes perfect sense.
Yeah.
Work really hard to make sure we're answering the call to question from the legislature. I think it's always important with these legislative reports to answer very clearly what it is the legislature is asking for, and provide some brief narrative about alternatives just to help make sure that they've got other options that they can consider. But I think it's always really important in these reports that it's something I learned years ago from the magnanimous Pete Cutler, who taught me the lesson of making sure that our reports are very deliberate in responding to what the legislature is asking for. They know what they're asking for, they know why they're asking for it, and so it's our responsibility to provide them with clear and concise information that is on point to what it is that they've asked for in our report, which is why we've come to where we have so far. And there's a lot of different options to consider what the future of it could look like, and there's a lot of different policy considerations that we can touch on briefly for them. But I feel the importance of this report in combination with other reports and other work that's been done, other conversations, is that we're doing our part to be really diligent in providing that information for them in the policy-making process that they will undertake should they choose to engage in a legislative process of consolidating the programs and what that might look like.
Hey, can you move us on to the simple conversation of eligibility? Sarcasm inserted.
Yeah, let's do it. So we're going to talk a little bit about the eligibility framework that we've conceptualized here for consolidation. Now, as you recall, not only in the requirements, but also in the considerations, the legislature made it very clear that they wanted to have the eligibility that currently exists in the PEB and SEB programs to remain and not be changed. And I think this was really wise on them because of the sheer complexity of eligibility that exists in particularly the PEB program, but also in the SEB program, and wanting to figure out the ways that we can make sure that doesn't get wouldn't be adjusted unintentionally or amended unintentionally in a consolidated program. So next slide, please. In order to establish a kind of framework to preserve all the existing eligibility, it was decided that we needed to categorize 3 different populations and adjust current definitions that are in statute. So under the current eligibility, we have definitions for employees, which were particularly assigned to the PEB program, and that consists of all the state employees, including higher education institutions, elected and appointed officials of the executive branch, the justices of the Supreme Court, and all their justices down to the superior courts, member of the state legislature, and employees of employer groups. And if you recall, employer groups are also what we call political subdivisions, but that would consist of things like of entities like cities and county governments, municipalities, water districts, hospital districts, and other governmental entities that aren't state agencies or higher education, but are permitted to contract with PEB or SEB to have benefits for their employees. Then we also have a definition for the SEB program employees, and that a lot simpler. It's just the employees of all school districts, educational service districts, and charter schools. And then as of last year, the SEB employer groups, which are defined as the employees of tribal schools, the employees of associations representing school employees, as well as it would also include school directors. And then we have a large array of a bucket of population that we refer to as the retired, disabled, and separated employees, as defined by RCW 4105080. So that's kind of the current populations. We could think of it, it kind of mirrors a bit the risk pools, but there are certainly some differences. But because eligibility is, that there's the non-Medicare retirees are in the non-Medicare risk pool, but when we're talking about eligibility, they fall under the category of retired, disabled, or separated employees. So not quite synchronous, but you can kind of see some similarities in those groupings. Next slide, please. So there's a lot of statutory and rules related to that eligibility. We have substantial sections of statute on 4105065 pertaining to eligibility for PEB employees. We have the statutory authority for SEB employees, and as well as the statutory authority for participation for retired, disabled, and separated employees. And those are listed there for anyone who wants to really get down and dirty into the weeds of rules and policies and statutes. Next slide, please. So when we consider consolidated eligibility, we came up with this framework considering those 3 categories of the existing populations that are served by both the PEB and SEB program. We try to keep some things similar, but we're doing a little bit of an adjustment on the way that we would frame them in statute and define them. So moving forward in a consolidated program, we'd recommend that there be a population we refer to as state employees. And that would include all of the, be very similar to the existing definition of employees for the PEB program, but it would remove the employer groups out of there and any of the groups that participate by contract, or those who kind of have more permissive ability to participate in the program. So the state employees would include, the state and higher education employees, the elected and appointed officials, the executive branch, the justices, the Supreme Court, and other judges of the appellate and superior courts, and members of the state legislature. And these are all the groups that are required to have their benefits purchased by the consolidated program. And then we would have a school employee definition, which would mirror what is currently there, which would be all the employees of school districts and educational service districts and charter schools. And again, we remove that employer group portion of it because they are permissible participants in the PEB program. And next slide, please. All of those that we removed from that definition would now fall under a category we call other eligible subscribers, which is going to include the separated employees, the retired or disabled public or school employees, and their dependents, surviving dependents of public and school employees, surviving dependents of emergency personnel killed in the line of duty, formerly elected or appointed officials and legislators, school board members, the employer groups, and the retirees of formerly participating employer groups. And these are all the rest of the population that exist that really don't fit in with either the eligibility framework for state employees or school employees. And just a way for us to be able to consider how we would maintain the eligibility structure moving forward, merging all of the eligibility requirements. So next slide, please. So important to note is what would not change, because that is really the intent of what the legislature is asking us, is conceptualize an eligibility framework where you can bring all of the existing eligibility requirements to a single consolidated board without changing any of that. So it's really important for us to highlight what's not changing, which is aside from some definitions of what the populations are and defining those populations, the eligibility would not change and would not have any crossover, which is why we have that framework. So it's important to note that the hour requirements unique to either the employee categories would not change. In the PEB program, that eligibility threshold is set at 630 hours per school year. On the PEB program, I know Dave was going to quiz some people. I don't know if Dave wants to do any quizzing of the PEB board about what current PEB eligibility is, but it's suffice to say it's 80-hour average for 6 months, and then maintenance rules that apply to it afterwards that are different. So none of that would be changing. The eligibility determinations on the PEB program that has to be done at the start of every school year would not change, nor would it apply to the PEB, the state employee category of individuals. The 8-hour maintenance rule for the state employees would not change. The faculty average for state employees, for higher education, would not change. And the eligibility for seasonal workers would continue to apply only to the subset of state workers that meet the definition of seasonal workers. Next slide, please. So before hopping into the single portfolio benefits, I just wanted to check and see, Dave, if there anything else you wanted to add about the eligibility framework, or see if there's any questions.
I don't have anything to add. I think that last piece, we really are fundamentally thinking of this part of the report as a question of, ministerially, what do you do to put statutes together under a single statute? Again, and I think many people were concerned that, or maybe hadn't interpreted the word maintain eligibility as meaning don't change things, but that is what we understand, and why we wanted to kind of level set and reinforce with the stakeholder community and the boards that we do not see the question before us as change eligibility anywhere. Make sure you can tell us what is necessary to write it in a single cohesive spot. So we really do think of it more ministerial, if you will, than a substantive question. But it is not to be underestimated how difficult it could be to actually write the words in a way to make sure nothing fundamentally changes in an unintended way. So it is a body of work.
Yeah, there's going to be a lot of writing for my team to get that language correct in a consolidated statute. But we feel that framework makes the most sense and will allow us to pull forward all the existing eligibility and have it clearly defined to the populations for which those eligibility rules would apply, and as important, which populations those eligibility rules would not apply to. Hence being the way that would make sure that there's not any unintended crossover of eligibility. So that, why don't I go into the last portion, which is the requirement of having a single portfolio of benefits. Next slide, please. So just a brief comparison on the current benefits portfolio. On the medical side, medical benefit, you can see that there's some difference in the number of carriers and the number of plans available between the PEB and SEB program. But aside from that, the availability of different plans and carriers for dental, vision effective 2025, certainly not currently, but forward thinking enough that any work that would be done would occur in 2025 or beyond. So we're looking at dental having the same number of plans and carriers, and the life, AD&D, and LTD carrier and plans available are the same. Next slide, please. Just a quick comparison of some of the costs associated with the medical benefit, because that's where there's actually the most variation between the two programs. You can see here the premium differences for the PEB non-Medicare and the SEB program. You can see the split there is the member portion or the employee portion of the premium for an individual coverage versus full family coverage. So you can see the range from $26 and $72 on the PEB side up to $331 or $910. And then you see a commensurate side on the SEB where 21 and 63 or 237, 711. You can see some of the differences. The deductible are fairly pretty negligible. In fact, no, they are identical. The out-of-pocket max is different, just very negligible depending on which plans are there. And then the co-insurances have some differences, with some plans having a co-insurance of up to 30% on the SEB side. On the PEB side, it only goes up to 20%. So it's just some of the financial plan design differences between the PEB and SEB program. Next slide, please. Let's talk a little bit about the differences on the dental side. As far as Delta Care and Willamette plans go, they are identical in both the PEB and SEB program. There is some differences between the programs on the uniform dental plan, though. In the SEB side, there are some enhanced benefits for a waived deductible for children up to age 15, an increased plan coverage for crowns and posterior teeth composite fillings, and increased benefit for non-surgical treatment of temporomandibular joint or TMJ disease. And that difference there is as a result of increased funding that was bargained for by the SEB bargaining coalition, and the benefit change that was made by the board in selecting by the SEB board to select the increased benefit for the out-of-pocket max or the waived deductible and the coverage for crowns, the posterior composite, and the increased benefit for TMJ. That was part of the increased funding that was bargained for, and that then the SEB board decided on that particular plan design to enhance the dental benefit. So that's the difference that exists in the UDP plan. The vision plans moving forward in 2025 will be identical. The life insurance and AD&D plan are identical. The long-term disability plan is the same as far as the supplemental version. The buy-up portion of that is the same for both the PEB and SEB programs. The difference is that on the employer-paid portion, there's a slight difference in that maximum benefit, where the PEB program has a maximum of $240 a month maximum benefit, and the SEB program has $400 monthly maximum benefit. There's just a difference in the cost. I think the amounts that are paid by the employer are the same. It's just what that, the risk on the SEB side for LTD is a little lower, so they're able to have the money stretch a little bit further to reach that $400. But really, when you're considering this being income replacement for someone who is disabled and have already reached the 90-day waiting period, the difference between 240 and 400 is pretty small at the end of the day. But there is that difference in the employer paid benefit. Next slide, please. So when we're thinking about a consolidated benefits portfolio, there's going to be a lot of dependency on what the consolidated board would do as far as what the plan designs would be. Some anticipations that we have regarding the non-Medicare portfolio, again, appreciating that we wouldn't be doing anything there's not a requirement in the report, nor would we anticipate making any changes to the Medicare portfolio of benefits. But on the non-Medicare side, some of the anticipations we would have is that the contracts for medical care, the medical plans would be able to be better leveraged, given that the population that would be under each of the contracts that could be served is now essentially doubled, instead of covering the PEB non-Medicare and SEB non-Medicare populations. There'd be a single portfolio of medical plans, which would likely result in having more options available throughout the state. We know there are some areas where there's fewer plans available throughout the state. So to have the consolidated portfolio would grant us greater leverage with existing contracts and potential future contracts in which we could leverage to have greater availability of plan options and carriers throughout the state. In a single portfolio, we also would anticipate that there would be one set of dental plans and vision plans, one UDP plan option, one set of UMP plans, one set of Kaiser plans, which has a significant benefit for our administrative wise for us in the contracting and creation of the certificates of coverage and a lot of the administrative work that goes into that. And then there's also, as I think Harry was speaking about earlier, raising some good foresight about the impacts that a consolidated portfolio would have regarding the employer medical contribution or the EMC, as well as aligning the tier ratio alignment. If you recall in the SEB program, there's a requirement in statute that it be a 3-to-1 ratio between the cost to the member for the full family coverage and the individual coverage. So if an individual coverage for a plan for in the SEB side is $50, that the full family cost cannot be more than $150 for that same plan for full family coverage. In the PEB side, that ratio is a little different. I believe, Dave, and you can correct me, it's 1 to 2.75 for the employer portion of the premium between an individual and full family.
Correct. So they just need, in a consolidated world, this would need to end up being a single number.
And what that number we wouldn't know. That I think there'd have to be funding questions about it. Again, what the employer medical contribution is and how that number is being determined, and how that's being used in bargaining, and then what the funding rate would be from the legislature for the consolidated programs, and what those numbers would be, and then the commensurate employee premiums that would follow after knowing what those numbers are and the different plan designs. And let's see, the last slide, please, or the next slide, please. Again, just wanting to highlight, there's no anticipated changes to the existing Medicare portfolio, just as there's no anticipated changes to the Medicare risk pool. There'd be no changes as a result. There would be no necessary changes as a result of consolidation for the Medicare portfolio. And also just wanted to acknowledge, and this is some of the work that we'll begin more with our stakeholdering next week, saying, what are the actual impacts to members? It'll be difficult to say, not knowing where the consolidated board would land on plan designs and the costs, and of course knowing what the carriers are going to be coming to and what carriers are going to be offering plans to the state and school employee populations. But we would anticipate, based on our understanding, kind of some of the historical context that we have, as David mentioned earlier, we finally do have data on the SEB population, which we didn't have back in 2020. That we know that there'd be some difference, plus or minus of about a percentage point on the employee portion of the premiums based on our current understanding of the risk pools if there was a consolidated risk pool. Because that's where that consolidation of the risk pools is going to have that impact on the costs for the members and the premiums that are being charged by the carriers, and then having the particular split between the employer and employee portion of the premium and what that would come down to. Hard to predict what that would be, but we don't anticipate it being very significant, like a note here, about 1% based on our current differences that we note between the risk pools for the non-Medicare SEB and PEB populations.
So I'm going to ask people on that last bullet to really not commit that one to memory. Tanya reminded me this morning, and in fact, we're going to be removing that bullet from this presentation as we go out for further stakeholdering, that the basis for that statement was pre-having SEB data. And so it's extraordinarily preliminary. So, I would just ask people to not focus on that. And it's based on such historic data at this point that we're really going to remove that as a talking point. So just please don't fixate on that.
Yeah. So ignore what I just said.
Yep, this is Elliot. I am concerned, if we look at page 24, about the uniform dental plan under SEB of the waiver of the deductible for children with dental benefits up to age 15. This is not a large population. It's to practice in dental law. And I would, since you will have more, power if you combine the boards, more leverage, I would hope you would keep this benefit and maybe apply it to the PEB members as well. That's my comment.
Thanks, Elliot. for this section, we're kind of cataloging some of the major differences that would have to be reconciled. And I know that there is concern that, would this be maintained or would it be rolled back from the experience essentially of the school employee that this whole process, if there's a consolidation, is going to be a multi-year process. And between now and then, there could be actions that are taken to address differences that exist between the portfolio. And an example could be the legislature could provide this board with some more funding to make dental enhancements. That's something they could do. And if they did, then this may no longer be on the catalog of things that would need to be reconciled by a singular board. But I think, with these differences in UDP, the funding request was made 2 years ago for both programs. It was picked up by the legislature at the time for just the said program. But the clinical basis for many of these, posterior composite fillings, wanting to remove barriers for a parent taking a child for preventive care, all of those are still fundamental, like policy reasons that would, may justify that expansion into the existing PEB portfolio or a singular program in the future.
And so my comment is recommending that approach to make sure that nothing's taken away. And in fact, we could take advantage of our leverage to add this benefit for PEB members, active PEB members.
Thanks, Elliot.
Any other comments or questions about kind of the talking points we have about the consolidated portfolio, or not a single portfolio?
I do have one question. This is more curiosity. I'm looking at the current benefit portfolios. That's slide 22. And it says there are, for PEB, there are 3 carriers and 10 plans. And for SEB, there are 5 carriers and 17 plans. I think the 2 different carriers for SEB are Kaiser Washington Options and Primera. And I'm wondering if, and maybe Louis, you can address this directly. When the SEB was created and they were looking at all of the different plan options for school districts across the state of Washington, it seems to me Primera was a fairly big player in a lot of school district options. And so I'm wondering if that's why these 2 plans were included in the formation of the SEB, and if there was ever any consideration for making them an option for the PEB.
You said Lou, but I'll take that one. The answer to all those is yes, yes, and yes. The Primera in particular, well, all of the carriers that ended up in the sub portfolio had some relationship with some segment of this prior K-12 benefits world. But Primera did have a 50-60 year relationship with the WEA, and the WEA had the trust that had extensive coverage for many school districts in the state. So I think there was an extraordinary interest by many school employees and members of the SEB board, hopeful that Primera would be among the successful bidders in a procurement. But we did a competitive procurement, and there were ultimately 5 carriers with these plans that were authorized by the board. We went through a 2-year exercise here with the PEB board back in 2021 and 2022, I think, or maybe it was 2020 and 2021. It was during pandemic time, so easy to kind of forgotten about it, about potentially migrating plans from the SEB portfolio over into PEB. And then after we had those discussions and they did not pencil out into a decision that the board there's dynamics that didn't quite pencil out as being kind of the best way forward on the portfolio. We went in the other direction and said, is there anything to take from PEB over into SEB? And same result, different reasons. So yes, there were different attempts to look at how to align, because one of the most classic questions that gets asked is, why are there more plans in SEB than PEB for medical, and why are there more options? So in a singular world, that would have to be reconciled. And at the end of the day, everybody everywhere would have the same options based on the geography in which they are located in the state. But yes, there were extensive attempts in trying to find some way to align those medical portfolios at all, and just has not been able to pencil out. Yeah. Harry?
We go to chart 25. Just a thought, Kate, I guess, or Dave, on the sub bullet, I guess, in this contract for medical and better leverage for service, blah, blah, blah. I think it's a little clumsily worded. least it is to me, because it applies to a lot of things I'm not sure actually could happen. I think for sure what could happen with this is service areas can be enhanced. There's no question in my mind about that because of the increased population. The PEB members could be enhanced by getting into counties where we currently don't have enough coverage to have certain things. So I think that for sure. But I don't want to suggest that premiums would be leveraged or bid rates would necessarily be leveraged because it would be larger. You know, in and of themselves, as we talked a little earlier privately, the two groups in and of themselves, the two BMS, whatever the big guys in the state of Washington. There is nobody bigger. So bigger isn't necessarily going to be better, but it cost wise, but it would certainly be better coverage wise, or to me. So I just wanted to make that distinction. The way it's worded now, when I first read it, I thought, well, contracts for medical. First thing I'm thinking is, well, rates, premiums, and all that. And that's not necessarily so. But if the second part of the sentence, leverage for service, if that is to mean service areas, for sure, I would agree with that. So I'll just be a word of caution on taking real care in how we word that. So we don't suggest something that might not be deliverable. Thanks.
Appreciate that. Kate, can you just round out real quick the stakeholdering process we're about to go over, and then we can quickly get to public comment.
So real briefly here, we've got into our stakeholder engagement feedback, just to let you all be aware. We're here today soliciting feedback from you, the PEB board, as we did yesterday with the SEB board. We have additional, or kind of the next kickoff of our larger stakeholdering of this. We're using the largely the same report. Will begin next week from today. We have a large general information meeting scheduled for the 18th, and then we'll be leveraging existing stakeholder meetings through the August 15th timeframe. Then we're asking that anyone that's wanting to provide written feedback, at those sessions, we're going to be doing more of a Q&A. We'll just answer some questions. We'll be presenting this and giving the information that we've shared with the board here today, and maybe some additional details that we have them fleshed out. But we're asking that the feedback be provided by stakeholder groups and those who are impacted to provide written feedback to us by August 16th, so then we can consider that and take into consideration the feedback we get on finalizing a report for mid-September timeframe. Next slide, please.
Yeah, hey Kate, I'm sorry to interrupt. The stakeholder, the meeting you talked about on the 18th, I think it is. Did I see that right?
Yeah.
Is that online? I mean, can you watch it?
It is going to be a Teams meeting.
Okay.
And we can certainly, if board members are interested, but I think we sent out invitations to like roughly 150 people. It's a wide range of stakeholders. It's labor leaders from PEB and SEB. It's benefit administrators from state agencies, higher education institutions, and school districts. It's carriers. It's legislative staff. It has a wide range of folks that could be interested on the topic, and health advocacy groups.
Yeah, I'm not encouraging a big Zoom meeting or something like that, but there's a way to tune in without being invited. But
we're also planning to record part of the general information session next week, and we can make that available.
So is this meeting a hybrid?
This
July 18th.
No, it's going to be all virtual.
All virtual. Okay. And so when you mentioned all of those various groups, have you sent out contact so that they in turn can email or get a message out to their constituents about this? So are they just the leadership teams that are invited?
We're trying to ask, because even with the breadth we already have is several hundred people, or between 100 and 200 people, and it kind of keeps growing. We weren't envisioning as part of the stakeholder process engaging with all 685,000 members between the covered lives. So we're hoping that the a representative democracy, so to speak, serves as a raising up kind of the questions, comments, concerns, ideas on behalf of the general population that everybody's serving. So I don't anticipate that it's something that would be in newsletters for retirees or a broad social media blitz from the healthcare authority to come join this meeting. It's designed to be more of the stakeholder leaders engagement.
Good to know, because I think I've been too much.
All right, just moving to the next slide. So let's just reiterate the 4 main points of consolidation considerations that we're putting in this report. Again, we have putting together, conceptualizing a single board, a single risk pool for the active non-Medicare population, maintaining all the current eligibility for all the populations that are currently served by either board, and having a single portfolio of benefits. With that, our next slide, please. We have our written feedback again due the 16th of August. For anyone who's listening that's thinking about putting in feedback, just put that on your calendar. Know that's when we want feedback by for to be considered for the report, and that our report will be submitted to the legislature. All things to right now, we're on track for December 1st having that turned into the legislature. With that, I think that is the end of the presentation. Sorry for taking a lot longer. It's an interesting topic, and happy to answer any questions.
Any additional questions or comments for Kate?
Good work.
All right. There we go. Thank you, Kate. Appreciate your time. Dave, next year's schedule?
Behind tab 10, you have the same order of dates that I presented at the last board meeting for next year's schedule for January through July. The only thing that's been published, so it's signed, sealed, delivered. Please mark your calendars. The one piece I'll again note is we have 4 meetings scheduled in July, 1 each week. We almost never have actually 4 meetings. In fact, this year we're having just this one. The rest are canceled. But we schedule them because it's easier to schedule the cancel meetings. We most likely will use at least 1, usually 2, but please hold them all. And as we get further into next spring, we'll be able to share in advance what we think will actually happen in the month of July. I will just highlight as a preview of coming attractions, when we get back to the retreat in January 30th, we know that we'll have a new governor. We will have budgets that are proposed in the legislature. Session will have started. Open enrollment will have happened. This report will have been delivered. Those are all topics that will be talked about and more. Hard to predict the future for 6 months from now otherwise, but those are things that we know will be there, and we always have an educational topic. So I'm just looking forward to when we start up next board season, even though we're celebrating ending one board season today.
Perfect. Public comment. Do we have folks in the audience who would like to make some comments?
Right here.
Mr. Yancey.
Good mid-morning. Before I 3 things I'd like to comment on. Number one is, again, just publicly thank Ellen Wolfhagen for all her work on the Medicare issue. She's been invaluable and has really added quality to the whole Medicare discussion. Number 2, a profound thank you to both the staff and to the board for the entire season's worth of work. Been a tremendous amount of data and very complex sort of issues with the board, and the staff has done excellent presentations throughout this whole season, and the board has done very well in terms of paying attention. Third thing is I'll just kind of repeat general remarks that I made yesterday regarding the consolidation report. What I find and my concerns, and I'll submit written comments about this too, but what I find is that it's missing any sort of analysis. So what? You got 3 boards, 3 board scenarios. What are the pluses and minuses? Should you choose any one of them? What are the pluses and minuses of consolidating the benefits? What are the pluses and minuses of consolidating the risk pool? You've outlined all the kind of possible scenarios, not all of them, but you've outlined a representative sample of scenarios conceptualized, but there's been not the added piece that the analysis of them, and that's the piece that if I was reading this report, my answer would be, my reaction would be, yeah, no, what do I do with it? So anyway, that's my thought, and I look forward to continued work on this report. I know it's an unfinished product. Again, the name is Fred Yancey. This is on behalf of the school retirees and also the school administrators, which I represent WASA as well. Thank you again.
Thank you, Fred. Next up.
We have Aruna Buta.
Aruna?
Good afternoon, Chair McDevitt and all the board members. This is Aruna Buta, RPEC member of Spokane. I have two or three. First, I want to thank Ellen for all her work, and I hope we will have just equally competent and cooperative person helping the retirees uh, figure out the maze of Medicare enrollment. My question was around UMP with Part D plan incorporated. Are the pharmacists going to be educated about this new plan so that people don't have the difficulties when the January, starts and then when the new enrollees begin accessing this UMP with Part D plan that is incorporated? That is my first question because quite often it is difficult, when the providers don't know about the changes that are happening. Can I go to the second question?
Please do.
Okay. And the other thing is, can healthcare authority promote all the uh, Medicare plans that are offered to the retirees equally? Because when I go to the benefit fairs or when I'm looking at the webinars, there is more promotion by the UHC Medicare Advantage plans and the Kaiser Permanente. There are huge lines at both of those booths. But as far as Plan G is concerned, offered by Primera, there is one single person sitting in the corner, and people don't know about what a viable option it is by remaining on original Medicare and getting the coverage that you need depending on your health needs. So can we have equitable representation of all the plans that are offered by PEB, by HCA at the benefit fairs, as well as in the newsletters, etc.?
Ruta, I just want to thank you for, I've received some comments that I wasn't quite sure the context, and actually the way you just provided that public comment helps me understand the nature of the other feedback I was receiving. And I think, how the carriers staff benefits fairs is something that we can talk with the carriers about. Some invest more than others. We require that they all be present. And I hear you asking, and now I'm appreciating some of the other feedback that I wasn't quite clicking. So I just really want to say thank you for giving more context to the benefit fair question. We do have everyone there, but we could talk to carriers about the level of participation that they have. But they are all there.
Okay. Yeah, they are there. You are right. But the number of representatives of, say, UHC or Kaiser are much different from Primera Plan G, which is really more cost effective and more comprehensive for the needs of the retirees, especially with complex health needs. And my third point is the open enrollment period for the marketplace Medicare plans, which is widely advertised on television, by mail and all, is from first week from October 7th to December 7th, which is much different from our open enrollment period. Can you please also make it clear that PEB Medicare plans has its own, and it is not the same as Medicare plans that are advertised by the companies on television or in the mail? Because I'm also a Shiba volunteer, and I was trying to help people, and I could see that there was a confusion. Oh, I have time till 7th of December. No, you don't have time till 7th of December to make your changes. Can you please make it very clear about PEB open enrollment period versus marketplace open enrollment period, in addition to the changes that are happening this year with the dates from 28th of October to 25th of December? Thank you for this opportunity, and keep up the great work.
Thank you, appreciate it. Next up, Tony Long.
I missed my opportunity earlier, so I just wanted to thank Ellen very, very much and wish her everything well for her retirement. I have been involved for over a year now, pretty extensively through RPEC and Ellen, and particularly initially when I had a lot to learn, still do constantly. It's so complex, but particularly early on, she was very patient and gave me more of her time than was probably appropriate. And I recognize that and want to thank you, Ellen, and thank all of you actually for doing such a good job at encouraging more involvement whether it be from RPEG or the general retiree population. So thanks for your good work this year.
Yep, appreciate that. We'll pass that on. Christine Clark.
Success. Christine Clark, also from Spokane, Washington, RPEC chapter. Excuse my hoarse voice. It's medication affected. Thanks again for PEB. Thanks again for RPEC educating members to be more attentive to our healthcare authority and PEB board. We really have gotten a great education from not only RPEC, but also from PEB. The reason I'm commenting today is to advocate for people with rare conditions who are not well understood by the medical community. And sometimes our costs are increased because we seek care from the medical personnel who don't know how to find information about how to treat especially emergency needs for rare conditions. Somehow we as the consumers need to work more on educating medical personnel so that we get better treatment with less cost. Thank you.
Thank you very much. Pat Slauson.
Hi, it's really Jim Slauson. I'm her husband writing on her Zoom. I would like to thank all of you board members, particularly Mr. McRobert, who's an old acquaintance of mine. I had a personal issue that speaks directly to the mandate on the report about negative impacts of new rules. I came up against the 630 hour. I'm a substitute teacher, and I had to actually resign on a particular day to maintain my health insurance, and I had no health insurance for 7 days. In the past, this would not have been a problem. I would have walked over to the district office and signed a waiver and gone on my way. Somehow, that waiver option was rescinded. It would have been an extreme hardship for me to change to SEB from PEB on a Wednesday in May. So I just wanted to convey that Tom has more detailed information than you'd ever want to hear about the negative effects and the anxiety it caused. And I would like to see that waiver come back until you do consolidate the boards. So that's my comment. Thank you so much. And I am a little disturbed that nobody from Healthcare Authority, any part of it, got back to me about my personal concerns. I did send very detailed comments to the board, and I have yet to hear from anybody. So anyway, I do thank you for your work. I know it's long past lunch, so I'll say goodbye. Thank you.
Pat, I just want to let you know we are going to be reaching out to you. We've had a lot of information and understanding and evolving understanding of this particular issue in the last 2 weeks. I saw that you signed into the meeting just as we were finishing up an opening segment that I shared a lot of context about this exact issue. So we do record these meetings, and after the audio file is up in the next couple of days, I really encourage you to, if you can, to sign in and go on our materials page and listen to the very first maybe 20 minutes of the meeting where there was some context about why the waiver that you were experiencing before really isn't allowed under federal CMS requirements and should never have been allowed in the past couple of years, and isn't something that either the PEB or SEB board can really allow going forward. And we're trying to right the ship to be in compliance with federal requirements. And now that we have more of an understanding as to how to explain this to individuals, we're going to be reaching out to school benefits administrators more. And you were also on the list to circle back with as we've had a more evolved understanding of what led to this really rising up among both retirees and school districts in the past couple of weeks. So there will be outreach, but I would encourage you, if you can, to once we get the audio link up, there would, I think, be some helpful context on this issue as we are reducing a lot of it to writing and getting communications out to people.
Well, thank you for that information, and a personal contact would be appreciated.
Yeah, absolutely. Thank you.
All right, thank you. Next up, Annette Farka.
Thank you. First of all, again, I want to thank the board members for all of the time and effort they put into working on the behalf of those of us who have the PEB, various PEB insurances. Secondly, I want to follow up on what an earlier speaker said a few minutes ago about Plan G. Plan G is an excellent plan for many people and meets many people's medical needs. Unfortunately, they don't understand it, and the information that's available in various places not only is limited at the benefit fairs, it's extremely limited in the PEB retirement booklet. And I think if there could be a way that you could provide a little bit more information, better explain why the whole supplemental plan chart, it has to be published because that's a requirement of CMS, and that because one plan is offered, you have to put the whole chart there. People don't understand why there only is Plan G. There needs to be some kind of an explanation that, hey, Plan G is the best supplemental plan out there. That's why we are offering it. And it better explain that, how a few page or two of how it works, so that I think you'll find that more people will be looking at Plan G and not necessarily doing it just because we are, some of us, SHIVA people are, when they come to us for help, are recommending Plan G. It's, and I don't know how, I know you have to follow the federal guidelines on how you deal with the Medigap plans or supplemental plans, but in terms of meeting people's various medical needs, the fact that there is no quote network you have to deal with, and the fact that your out-of-pocket costs can be exceedingly reduced is something that needs to be looked at and emphasized as a viable option for people anywhere in the state or out of state who happen to be in PEBB as a Medicare retiree. Thank you.
Thank you. And Kenny Washington.
Hello, my name is Kenny Washington. I just had a comment. I know we were talking about risk pools before and after consolidation. I work for a public hospital. I'm not sure if everyone's aware. Half of all public hospitals in Washington State, half of all hospitals in Washington State are public hospitals. And there's 54 public hospital districts, about 118,000 employees, from administrators to nurses, doctors, the whole nine. And I don't see an representation in the risk pools for public hospital employees, as well as kind of like the new recommendation to the legislature about combining risk pools from PEB and SEB, having the same representation of public hospitals in those avenues as well. I see there is a place that says state and other employees, but I don't see a representation of the 118,000 public hospital workers in Washington State. So if anyone has some other information on that, maybe there is a representation. I'd be interested in being able to give that information to the people that I work with, because we are covered under PEB, but I don't see a representation of our 118,000 employees. Thank you.
Hey, Kenny, sometimes I engage to give some information in real time because I think it's more helpful than just follow. And this is one of the things I want to share is you are correct when you see other, state employees and when other employees. Public hospital districts are an example of one of the other political subdivision employer groups that can join voluntarily into the PEB program. We have about 325 employer groups, counties, cities, municipalities, public hospital districts, water districts, irrigation districts, library districts, a lot of things that have the word district in it. I will have to go back. We have a number of public hospital districts that have joined the PEB program. The totality of all the covered lives in the PEB program that is attributable to every employer group is about 16,000 lives. So I'd love to understand, and we'll reach out, have someone reach out to understand a little bit about, it seems like there are rather large hospital districts that have not opted in. So I just wanted to make sure everyone was aware that we do have hospital districts. We don't have all hospital districts, and so and the totality of our political subdivision covered lives is around 16,000 right now. So I'd love to, circle and understand, but you're right, there isn't a current representative on the board that's related to the employer group process, and where you would see public hospital districts is under that employer group header in the materials and in statute. But we can certainly connect on some more details, because we're open for all public hospital districts to join the PEB program.
Yeah, I was thinking about the total population in PEB itself is 133,000, and so
about
it can't be that the hospital districts make up 98% of that. So there are portions, but I think Dave is going to get you back some more detailed information on that. But your comments are appreciated.
Yeah, absolutely.
This is Elliot. I am the PEB member who represents retired state employees. And I know that there are retired state employees who retired from public hospital districts. And they do contact me. They're members of the Retired Public Employee Council. But yeah.
Yeah, so we definitely have some members who come from public hospital districts, but we definitely don't have all public hospital districts. All right. We're always welcome more friends.
Yes.
So this is probably a question that you might have to direct to somebody like Shatrina, but when she was talking about the lack of information about Primera, and you look at a website like Consumer Reports or Amazon, sometimes you can say, do a comparison. So you click on, like you have maybe 7 or 8 choices, and you click on 2 and it'll line up the benefits next to each other. And that might be something that would address what she was talking about, but it would probably have to be a tech solution to create that kind of a situation.
We have some level of plan comparator tool, so we can double check and see how that lines up with that idea. But there is the infrastructure for something like that we either already have or can leverage. So thanks, Tom.
Yep. All right. Many of us have a 1 o'clock meeting. I know some of us are just gonna go have lunch and do stuff, but
I'd like to acknowledge the support staff, Jessica and Mackenzie, others, IT, who are able to do all this, because sometimes we forget about those. So keep them in mind.
all right. Looks like our next meeting is going to be January 30th, 2025. It'll be the same format, in person or via Zoom. I do want to appreciate everybody who made this board season happen. It was kind of fun here to jump in at the end with you all as we round out the season. Dave, any final comments?
Have great summers.
Great summer, everyone. Thank you so much. Take care. Oh, yeah.